can wait for 2 minutes for the audience to join in.
We are live.
Yeah.
I think we can start now. We can go on live and are you on live now, Jay?
Yes, sir, we are live. We can start, sir.
Okay. Tulika?
Yeah, I'm ready.
Please wait. Can't see anything on the speaker of viewers link. Please click the viewers link before you start. I'm also on the viewers link. Nothing's coming there.
Are you on the YouTube?
Yes, sir, we are live. We can start, sir.
Okay.
Bhaskar, check.
Yeah, it's fine. Carry on.
Bhaskar, sir, can you please...
Yeah, we're on. Start. I'm also on the viewers link.
Yes, sir.
Nothing's coming there.
Okay.
Okay. Tulika, go.
Respected seniors, dear colleagues, friends, ladies and gentlemen, a very good afternoon to all of you. Hope you all are safe and sound in these most troubled of times. It is indeed a pleasure and privilege to welcome you all to the 62nd Sir Kedarnath Das Memorial Oration, which is being held today online for the very first time. As is customary, this oration is usually held in Arjikar Medical College because Sir Kedarnath Das had spent a considerable time of his professional life there. But like all other programs worldwide, we have to do it online this time for the very first time. We have a very special orator for this prestigious oration with us today. And to start the proceedings, I would like to invite the president of our society, Dr. Dibendu Banerjee, to deliver his welcome address. I would also like to invite our honorary secretary, Dr. M.M. Samsu Zoha, to the dais online. So over to you, Dibenduda and Zohada.
Thank you, Tulika. First of all, respected teachers, seniors, colleagues, ladies and gentlemen, it's indeed a pleasure and honor to greet you as the president of your society today on the occasion of the 62nd Sir Kedarnath Das Memorial Oration. It is our privilege and honor to have Dr. Tim Daycroft, the Vice President of the Royal College of Obstetricians and Gynecologists, amongst us today as an orator for this famous oration. As you all know that we are going through a very troubled times and we are not being able to meet physically. This oration traditionally used to be held in my alma mater, that is Arjikar Medical College. And we were very proud of it that we held, this oration was held in a seminar room which housed a famous forceps museum. But due to these changing times, we are being forced to hold this oration on a digital platform. On behalf of all the members of the managing committee of the Bengal Obstetric and Gynaecological Society, I wish you all good health and wish you all that you stay safe. With this, I would request Tulika Jha to take the proceeding forward.
Oh.
Tulika, would you please represent
yes.
the CV of Dr. Sir Kedarnath Das?
Yeah, sure, Zohada, sure. Amita. Amita, please share your screen. Amita. Amita needs to share his screen.
Cannot see Amita in the parts.
Okay.
Dr. Amit Basu.
Amit.
Yeah, he's having some network problem and he is going to share the screen in a minute.
Has the issue of the
Amit.
yeah, there.
Okay. Now, sorry
Okay.
for the
Nah.
issue. Shall I share the screen, Tulika?
Please,
Yes,
please,
Amita.
please.
Yes, please, Amita, share. Good afternoon once again, ladies and gentlemen. As I introduce you all to the great personality, Sir Kedarnath Das, it is my pleasure to be able to share his life journey with you all. Sir Kedarnath Das, in his early days, was born in Kolkata on February 24th, 1867. He was the second son of late Chadok Krishnadas and unfortunately lost his mother at a very young age. So this did not hamper his studies, and he completed his primary education from a local vernacular school. He then moved on to Hindu school to complete his secondary level schooling and passed the entrance examination with scholarships. He completed he passed the first arts exam from Scottish Church College and passed his final MB in 1892, exactly 100 years before I did, from my alma mater, the Medical College, Bengal. And it's all the more a privilege for me. As a medical student, he had received various prizes and scholarships. And he got college scholarships throughout the whole study period. He got 8 gold medals, obtaining full marks in midwifery. He had 10 certificates of honor, the Duke of Edinburgh Prize in Surgery, Prize in Clinical Surgery, the Prosector's Prize in Anatomy, Durga Charan Law Scholarship for being standing first in first MB, Abdul Ghani Scholarship for the Best Student of the Year, and the prestigious Goody Scholarship in Midwifery in Eden Hospital. He completed his post-graduation MD in 1895 from Madras University and became a fellow of the Royal College of Obstetricians and Gynecologists, London. Next slide, Amita. After finishing his studies, he became the registrar in medicine and then surgery in Medical College. He went on to become a teacher of midwifery in Campbell Medical School in 1899, which is now known as the NRS Medical College. He became the head of the department in Obs and Gynae in Carmichael Medical College, which is now Arjikor Medical College, in 1990. He was principal in the same college from 1922 to 1936, that is for a long 14 years. He was also the Dean of the Faculty of Medicine, Calcutta University, and an inspector of MCI under the British rule. He had a number of fellowships. He was the founder fellow of British College of Obstetricians and Gynecologists, which is now known as the RCOG. He was a fellow of the Royal Institute of Public Health, England. He was a fellow in the Royal Society of Medicine, London, and a member of the British Medical Association and president of its Calcutta branch here in India. He won several awards and honors during his lifetime. He was an honorary fellow of the American Association of Obstetricians and Gynecologists and Abdominal Surgeons in 1914. He was made an honorary fellow in 1923 of the American Gynecological Society. He won the Companion of the Order of the Indian Empire in 1918. And in 1933, he was awarded knighthood, which was, I think, the icing on the cake. He had innumerable publications and research work and highly valuable contributions to medical literature, especially on the subjects of postpartum eclampsia, menstrual pattern in different conditions and changes, vesicular mole, twin pregnancy, etc. But the most important thing for which we know him and he's famous for is the Das's forceps, which was popularly known as Bengal forceps. This will stand forever as a monument to his achievements. Monogram of forceps was also one of a historic compilation by the celebrated obstetrician, and this got worldwide acceptance. This is a picture of the Das's forceps. This is a picture of the museum about which our president, Dr. Dibyendu Banerjee, was talking about. This is a museum in Arjikar Medical College in our seminar room, which houses about 200 pairs of obstetric forceps from Sir Kedarnath Das's personal collection. Though his collection had many more, about 800, but 200 of them are displayed in this museum. Das's dilators are also very popular and widely used. This was also one of his inventions. And as a person, he was a great disciplinarian, a man of towering personality. Needless to say, he always maintained high ethical standards in his professional life. He was a perfectionist, especially in regards of medical education, and was a strict examiner. But he finally left us on March 13th, 1936, at the age of 69 years. This is the gynae department in Arjikar Medical College, which is also known as Sir Kedarnath Maternity Hospital. So this was, in short, the life and times of Sir Kedarnath Das. And we move on to the 62nd Sir Kedarnath Das Memorial Oration. And over to you again, Dibyendu, to start the proceedings.
Thank you, Tulika. Now I request our Honorary Secretary, Dr. Zoha, to kindly introduce our orator for today's oration, Dr. Tim Takeoff. Dr. Zoha, please.
Yes, just a minute. Am I visible?
Yeah. Go ahead.
Yeah. It's a proud privilege for me as Secretary of Bengal Ecological Society to introduce Professor Timothy Decker, MD, BSc, MBBS, first UG, Consultant Obstetrician, North Bristol NHS Trust, Professor University and Professor Decker qualified in 1989, studied in London and the South West England, spent valuable time working in France, Sweden, as well as in South Africa. Over the last 20 years, Professor Decker has led the academic department at the University of the Bristol and then University of the West of England, which is now recognized as world-leading interpretum care center, as well as for safety and research center. His current clinical role, he works as a consultant obstetrician in South Med Hospital, which comes under North Bristol NHS Trust, and as well as a professor of obstetrics in University of the West of England. He is a joint lead UK Fetal Surveillance Improvement Group, a chair NHS England Improvement Training Core Competence, clinical lead for a cross-government department shared outcomes with, as well as he is an external advisor of State Claims Agency of Government of Ireland. Team was chosen as elected as the Vice President for Clinical Quality and Strategy of RCOG London in December last year. He is also Director of Tommy's National Center for Maternity Improvement. Is Senior National Advisor for Maternity NHS Resolution. He is also a Special Advisor at Department of Health and Social Sector. He is a research and innovation lead on the very famous Prompt Maternity Foundation program, which is basically a practical obstetric multi-purpose professional training program, which has been shown to be effective in training and developing teamwork in the maternity team, and is being practiced over 70 countries now. His RCOG responsibilities include guidelines, patient informations, invited reviews, clinical quality board and academic board. He also looks after National Guideline Alliance. He is also in charge of the audit and clinical information section of the college, as well as Teach Baby Count program. He has got many prizes and awards on his name. He was awarded Hospital Doctor of the Year and Maternity Team of the Year in 2007. He was also recognized as NHS Hero in 2009. He was awarded the Queen's Anniversary Prize for Excellence in Education by Her Royal Highness Queen in 2014. He also got an international prize for patient safety, Robert S. Gordon Prize, in 2020. He has got innumerable publications in his kitty. He has got more than 130 peer-reviewed journal publications, 3 national UK guidelines, 8 national reports, 3 series of prompt training manuals, UK National Program for Operative Birth, the robust, author of most successful obstetric textbook in Cambridge University Press history. Ladies and gentlemen, Professor Timothy Draycott for you, and I have no doubt in my mind that he is the best person to deliver 60-second Sir Kedarnath Das Memorial Oration, and he will be speaking today on assisted vaginal birth in the 21st century. The screen is yours, Tim. Sorry. So with this, I welcome Professor Draycott.
So thank you very much. And let me just get my slides up. Can I tell you how much I would rather be in Kolkata than here giving the talk? Let me just do that. That's perfect. So thank you very much to the President, all the officers, all the members of the Bengal Society of Obstetrics and Gynecology. It is my absolute privilege, a really deeply felt privilege to be able to provide this oration. And I think that in his memory, Sir Kedarnath Das' memory, I'm going to celebrate his work and talk about what I think is the role of assisted vaginal birth in the 21st century. And I'm going to provide some really, really brand new data for you all. Now, I think I'm 56 years old. I always tell my juniors that I qualified in the last century. That's when I got my Part 2 exam. But I'm going to show you some data which I think is going to completely change how we do instrumental births in the next 10 and 20 years. So people who are younger than me, that doesn't look like the President, but people who are younger than me, I think it's going to completely change how we assist vaginal birth, and particularly the new Odon device. I'm not going to repeat Tulika Jha's fantastic review of Sir Kedarnath Das's life. And I just looked at all the things he got, and it just struck me the only person who could possibly make him look like an underachiever is maybe Professor Sir Arul Kumaran, another fantastic obstetrician of our time. We talked briefly about his forceps, his book on forceps, and I really enjoyed the picture of the museum and wish I could see the museum. I'm very keen on forceps. We still do Keelans in our department. We're very keen on forceps. And I liked his modification of forceps, and I thank the committee for sending me a very elegant paper that he wrote about his forceps. And really what he said was, because Bengali women are lighter and more delicate than UK women, then he needed forceps that were lighter and more delicate. And so he made his 6/7 the size, and they seem to have been extremely successful. So let me just talk about the role of assisted vaginal birth in the 21st century. So let me credit C.M. Perandre's joke. C.M. Perandre, another famous Indian obstetrician, president of FIGO, he always says, in many countries of the world, there's only two ways of having a baby: CS and AVB. It's cesarean section and accidental vaginal birth. Now, you can see that if you go to Nicaragua, Ecuador, Peru, you have less than 0.5% chance of having an instrumental birth. India is about 3%. The UK is about 10 or 12%. So who's right, who's wrong? And I think let's focus on what's right for women and their babies in this circumstance. Not so much for obstetricians. Let's really focus on what's right for women and their babies. Well, first of all, I'm going to say that cesarean section is not a really safe option. People think, cesarean section, that's safe. I'm going to have that because, vaginal birth is so dangerous. Well, cesarean section definitely has problems, particularly in future births. So we all know the risk of scar rupture. We know the risk of organ injury in future pregnancy. Okay, placenta accreta. So when I did my part 2 in 1995, you learned placenta accreta for the exam. It didn't ever really happen. Now, with the increasing section rates, I'm sure like many of your units, we now have a placenta accreta cesarean list every Thursday morning in our hospital that takes all the placenta accretas from the region. And look at this, the risk of stillbirth is doubled in your next pregnancy if you have a cesarean. So if you're planning one child, maybe it doesn't make much difference. If you're planning more than one child, then cesarean section is definitely not completely safe. If you look at the second stage of labor, then you can see that if you get to the second stage of labor, if you have a cesarean in the second stage of labor, it's higher risk of PPH, higher length of stay, and a much higher risk of your baby being admitted to the neonatal unit. And actually, if you're good at instrumentals and you can do an operative delivery, it's definitely quicker than cesarean section. So that is better for the baby too. But there are long-term consequences of cesarean section. It seems as if you're more likely to have childhood obesity. There are issues with possibly issues with allergies. And these are things that have long-term consequence. But let me show you, this is a really, really important new issue in the UK. And I don't know if it's an issue in India. It's certainly an issue in the States, and it's certainly an issue in Australia. But we're seriously having problems with impacted head at cesarean section. So can you see, this is a baby's skull. Each one of those dots is a skull fracture under a fingertip at cesarean section. Okay, this is seriously damaging babies. And in fact, if you look at the main indemnifier for the NHS, you can see that NHS resolution, we're now seeing more problems with impacted fetal head, or pretty much the same number of problems with impacted fetal head as we are with shoulder dystocia. And although there are national training and management protocols for shoulder dystocia that definitely have improved care, there's currently nothing for impacted fetal head. Now, I always think it's a bit like pushing a ball in a flower pot. How do you get your hand underneath the ball to take it out of the flower pot? Well, again, one of the unrecognized Indian contributions to obstetrics, modern obstetrics, is Padwadhan's technique. I apologize for my terrible pronunciation. And okay, up until the last year or two, that was unheard of in the UK, unheard of. And even today, less than 2% of people in the UK know how to do it. So again, I think we need to think about how do we work with India to improve care in the UK. Let me carry on with the risks of cesarean section. If you do a cesarean section at full cervical dilatation, you more than double your risk of preterm birth in your next pregnancy. doing cesarean in the second stage of labor is dangerous. Dangerous for the mother, dangerous for the baby, but also dangerous for the next pregnancy too. Probably because you're cutting through the cervix as it's brought up into the lower segment at full dilatation. And if you look at, certainly developing world settings, reintroducing assisted vaginal birth. Now, this was a paper from Mozambique, Uganda, and Tanzania, and they increased the instrumental rate from 1% to 4%. And just by doing that, they reduced maternal mortality by 11%, they reduced intrapartum stillbirth rate by up to 25%, and they also reduced perinatal mortality. If you can do assisted vaginal birth safely and carefully, it is better for mothers and babies. So why don't we use it more? What's the problem with assisted vaginal birth? Why is it only 0.2% in Nicaragua? Well, I can't tell you exactly what's going on in Nicaragua, but if you look at the world data, then there seem to be problems with availability of functioning devices. People are very worried about complications, and there definitely is an issue with training. So here is a good example from the States. This is a US residency program, and they said they need to at least 13 forceps in their 4 years residency to make them confident enough to do it in future practice. Well, 13 forceps might be a couple of busy weeks in my unit for a registrar. That shouldn't be a problem. And clearly in India, there are opportunities to train too. Now, this is just my video to make you smile about training. Is this how we should train for vaginal birth?
Sorry, what's the Shinyon? The ventouse is attached to the baby's head, like so. The doctor grips the handle and then pumps, creating a good, strong vacuum. And then with each contraction, he pulls, drawing the baby out. Now, the Kiwi ventouse can also be used for rotational deliveries. The force of this can create a swelling, a chignon, that will often take many days to subside. The chignon.
Now, I just want to tell you all, reassure you all, that is not an RCOG training video. This is from a TV program in the UK, and it just always makes me smile. And I said it to our juniors. We were talking about instrumental one day, and we're doing some teaching, and I showed them this video, and I said to our juniors, I said, well, clearly that's not a good way of training. And one of them said, yeah, that's not where you put it, is it? That's not the main problem of the training, is it? so let's see. So what can we do?
Sorry.
Whoops, here we go. Well, you probably know there is an RCOG training course for instrumentals, which is non-rotational births in your second year, and rotational instrumentals in your third and fourth year are now mandated. And I am absolutely certain that the RCOG would be very happy to share the training course with fantastic IRCs in India. So I hope I've persuaded you that assisted vaginal birth definitely has a place in the 21st century. However, its safe use does require, as we all know, accurate clinical assessment, skilled use of instruments, think about potential complications, and also good communication. Now, training can improve all of those elements, and we can make it safer and better. However, I don't know if any of you have seen this. Some of you have seen it. I'm sure I've demonstrated it on models in India. We've definitely been to see the Indian Medical Research Council to talk about this. This is the BD-Odon. This is the BD-Odon device, and I'm just going to show you a simulation of it. And it's essentially a plastic bag. It was invented by an Argentinian car mechanic. And this is just one of our simulation videos. This is Stephen O'Brien, this is his PhD. And can you see, essentially, it's a plastic bag, and you push the plastic bag over the baby's head, take off this sleeve, push the plastic bag over the baby's head with an introducer, take the introducer, then pump up a cuff, an air cuff, that sits just underneath the neonatal maxilla, or fetal maxilla at that point. Okay, take the introducer off, and then you deliver it in a J shape, just like you normally would. Now, so just to give you some images of that. Now, okay, I'm going to tell you, when I first saw this, I thought, absolutely no way. Okay, no Argentinian car mechanic tells us as obstetricians how to deliver a baby. And when I first saw it, I thought, okay, I just don't understand it, I don't get it, but let's have a look at it and see what the story is. So you put it on, can you see you push the plastic bag with these introducers, there's the introducers here, push it over the baby's head. Now, okay, everybody immediately says, why would I put a plastic bag on a baby's head? Well, it's not breathing until the chest is out. Always remember that. And if you're talking to women about it, that's really important to say. Pump up the cuff. Can you see the cuff then lies just underneath the fetal maxilla? And interestingly, we think it works by, as you pump up the cuff, it tucks the chin in, and therefore it works by flexion, the way that all effective obstetric procedures work. So take the introducer off and then just deliver it like you normally would. And the traction is provided by this air cuff. So we did nearly 3,000 simulations. We were very interested in lots of things before we did anything on women. Can you see that's where it sits? So you put it on exactly the same way for OA, OT, and OP positions. It's exactly the same way. So therefore, it should be simpler for junior obstetricians to put it on and people who are not very experienced to put it on. It sits slightly lower down for OP, but it never goes past the chin. So it never goes anywhere near the neck, and it doesn't, strangle the baby anyway. But can you see, when we looked at pressure curves over the baby's face, can you see that there's much more pressure on a baby's face with the forceps? You can see the curve of the forceps here. Can you see that? But can you see an inflated air cuff pushes much less pressure? It distributes the pressure across the baby's face in a much more shared way. When we first saw it, we were very skeptical. It was quite long. It was kind of this long. There was a metal bar in the middle. We didn't like that at all. It didn't look very elegant. And actually, we've now made it look more like, maybe we've done a DAS modification and we made it lighter and more delicate. And I am absolutely sure Sir Kedarnath Das would be interested in this as a man who is interested in instrumentals. So we were very happy with simulations. We published all this work, we thought it's good, but I'm just going to say, this is Carl Wiener. I know Carl Wiener is a very famous American obstetrician. This is his dog. And I always think the dog is watching the washing machine washing, it's not doing the washing. So sometimes you have to stop watching it and start doing it. So if you look at the original data from Argentina, they enrolled 49 women. These are all women who are multips, OA, pushing normally with epidurals in the second stage of labor. So none of them were actual clinical indications for instrumentals. Even then, there were some issues. Only 71% delivered. You can see an 11% cervical tear rate. Golly, that's high. I've very rarely seen a cervical tear in normal practice. But what they said was, okay, let's do some real research and try and find out. So we were funded by Gates. Interestingly, the Gates Foundation funded this research because they wanted to know, can we use this in a developed world setting, and then can we use it in mid-range settings and less well-developed settings too? So we decided, first of all, to do a feasibility study. Will women join in a study? That was the first thing we had to work out. So we did a feasibility study of 40 births, and the primary outcome Could we deliver the baby with the device? Secondary outcomes, all the ones in the Cochrane review. So we actually used a video for consent. I'm not going to show you the whole video, but I think for intrapartum research, and particularly for young women of today, when we said to them, would you like an information leaflet or would you like a video you can watch on your phone? Every single one said, I'll have a video, thanks very much. And so we started this video for consent, very, very successful, talking about how it works. And that's Joe, one of the midwives. I won't go through, I won't go through the whole video. And so then we had a look at the first 40. So can you see that 78% of women consented to be in the study when approached antenatally? These women were approached antenatally, and then the decision was made at the time as a decision for instrumental. So they were approached and consented antenatally, then checked and confirmed in labour. You can see that we used it for fetal distress in the majority of cases, delay in the second stage. We used it for OA, OT, OP, some epidurals, less no epidurals. But so the whole range of clinical indications in our service. Oops. Okay, so, and then you can see that we expedited the birth successfully in about 50% of cases. There were issues with the device failed a couple of times because there was a particular valve that needs to that needs just changing a tiny bit. Also, we were doing it up to 0 spines, and that's difficult. And there was definitely a learning curve. So, for example, it took us a while to work out that you have to put the Odon device on during a contraction. So completely different. There were no maternal serious adverse events. There were no neonatal serious adverse events. And it was interesting that women's perception of their birth was excellent, failed or not failed, in 97% of cases. So women were delighted to be in this research. I think one of the key issues for us, and particularly for women, was that neonatal pain scores were much better with the Odon device than they were with either forceps or Von 2. And can you see on the left-hand side is the data collection forms for all the babies who delivered by forceps, and on the right is one of the ones we delivered with Odon. There was not a single mark on any baby with delivered by Odon, and women really like that. We then moved on to Assist 2, which is what we're in at the moment. This study was powered for non-inferiority against Cochrane vacuum, which is 65%, but also powered for futility. At what point should we stop the study? We used a nested cohort design. We trained 4 new junior accoucheurs, a new training program, and a slightly different Odon device where the valve had been changed. Well, we've rapidly got up to 79% success rate. Now, these are for absolutely standard indications for instrumental delivery in the UK. So 79% is actually much better than the 65% that is the Cochrane quoted level for Von 2s. There have been a similar number of third-degree tears to Von 2s, and again, no neonatal side effects at all. Women were incredibly positive about their experiences of both this device and the study. And what was interesting was almost every single woman who's joined in the study has said that it was, if they can stop women having forceps in the future, then that would be definitely a good thing. We also started a second study site in France, in Besançon, and you can see they have an 88% success rate. Wow, well, 88% is getting on for forceps level of success. Now, you might think, well, maybe French obstetricians are better than UK obstetricians. We definitely don't think so. That would be embarrassing if that were the case. There is a big difference in France. They will offer to expedite the birth vaginally after 15 or 20 minutes pushing, whereas we would definitely go for an hour at the minimum. So some of the babies they have successfully delivered would have delivered vaginally anyway in the UK. But they also have very few, no serious side effects, some third-degree tears, and no neonatal side effects at all. So if you look at the ASSIST study, look at the Odon device. Number one, it is possible to do studies of new devices. Now, I am absolutely certain that Sir Kedarnath Das did not have to go for all the ethics, the research, governance, everything else we had to for this trial compared to his forceps. But I think it is really positive that there may be a completely new way of delivering babies, assisting birth vaginally with the Odon device, and at least 70%, maybe 88% success rate. The neonatologists in our department cannot understand why we use anything else. They are absolutely convinced this is better for babies than either forceps or vacuum. There are advantages for obstetricians because it's the same application for OT, OA, and OP positions. And if you ask women, all of them want a safer, kinder alternative for assisted vaginal birth. So if you just as a summary of the data, can you see, if you look at the line across the efficacy data is the 65% of quoted in the Cochrane review for Von-2s, and you can see that really assist is outperforming Von-2s already. In France, it's nearly as good as forceps. But can you see on the right-hand side, can you see the assist 2 and assist Besançon are closer to the complications of vaginal birth, normal vaginal birth, than both Von-2s or forceps. So it seems to be efficacious. It seems to have lower complications. And I think it's exciting enough for us to do more work in this area to try and understand, is this a useful thing to do? So I hope I persuaded you. It's been my absolute privilege and pleasure to present and be the orator for such a fantastic figure in the history of assisted vaginal birth. I think Sir Kedarnath Das would have been interested in the Odon device and interested in, okay, that's good, but do I need to modify it for India? Do I need to do something different for India because the birth weight is slightly smaller in India than it is in the UK? And I would love to have been able to sit down with him and have a chat about what we're going to do. Okay, there are advantages for obstetricians, there are neonatal advantages, and I think we've got to think about what do we do for next. Now, this current study is funded by Bill and Melinda Gates Foundation, and I am hoping that we can find funding for an Indian partner. And we're better. Bhaskar tells me every time I see him, we're better than Kolkata. We're better than West Bengal to do this kind of work. And I say, that's funny because in Mumbai, they say exactly the opposite. So look, thank you very much. Thank you very much to all the women who participate in our study, all the ASSIST team, all the midwives and researchers who are working with this, particularly Jo Crofts and Emily Houghton, who are the two obstetricians who are really doing the hard work here. BD, Becks & Dixon, and the Gates Foundation who funded it. Thank you very much to Sir Kedarnath Das, and I hope I've done his memory justice in speaking to such a fantastically prestigious society like yours. Thank you very much. I think you're on mute, President.
Thank you, Professor Daycroft. for this enthralling lecture. I feel that Professor Sir Kedarnath Das would have been proud to hear you talking on this assisted vaginal delivery. And it's been a pleasure for all, not only me, for all the members of the Bengal Society to have you amongst us. We would have been more than happy to have you here physically, but considering the circumstances, at least we've got you out here digitally. We've got a tradition of handing over a plaque after a oration. We've arranged for that, and since it's not possible to hand it over physically to you, we would hand it over digitally to you, but we will courier it physically to you. So it will be couriered to your mailing address, but I would request, I'd request our secretary, Dr. Zoha, to read out the plaque. Dr. Zoha, please. Dr. Zoha.
Here, no?
He's coming.
No, he's there.
Can I say while we're waiting for Dr. Zoha,
Yeah.
I would love to see the museum. I would love to see the museum. That's on my bucket list of things to see before I get too old.
Next time you're in Calcutta, we'll definitely arrange for it.
If you like it or not, I'm coming to see it next time we're in Kolkata.
Yeah. The invitation is on. Okay. Zoha, please get along with the plaque.
Right. Unfortunately, it is virtual meeting, so we cannot hand it over directly to a team. But we'll show you what. Can you all see? Can you all see?
No.
Is it visible now?
No, you are not. I'm not
All right.
sharing.
Okay. Is it visible now?
Yeah.
Right.
Full
So
screen.
that's the replica of what we will be sending it to Professor Team Record, and it read, on behalf of the members of the Bengal Obstetric and Gynaecological Society, it's a great pleasure and privilege to honor Professor Tim Draycott, FRCOG, Vice President, RCOG London, Consultant Obstetrician, South Med Hospital, and Professor, University of the West of England, Director, Tommy's Maternity Improvement Center, UK, for delivering 62nd Sir Kedarnath Das Memorial Oration live on Saturday, July 25th, 2020, and is signed by Dr. Dibyendu Banerjee, President, and myself as Honorary Secretary of the Bengal Society. Thank you very much. Thanks a lot. It was really a privilege to have you as orator on our program.
And
Thank you very much. It was my privilege. Thank you.
Yeah, and the plaque will reach you soon.
Thank you.
Okay.
Unlike COVID, I hope.
Yes, Tim, can I just make a request? We need to have your postal address.
I'll send it.
Okay. Thank you. Thanks a lot.
I probably won't read it out on YouTube.
Yeah.
Thank you, Professor Draycott, and thank you, Secretary, BOGS. Thank you, President, BOGS, Dr. Dibyendu Banerjee. Thank you, Tulika. And now it will be my pleasant duty to carry on the Foundation Day program ahead. We are about to start our symposium, and then the most awaited Dr. Bamondas Mukherjee Memorial Oration. So before the oration, we have a symposium where we have two speakers and who will be introduced to you by the chairpersons. So it will be my privilege to call upon the chairpersons to conduct the symposium. Before the symposium, just a minute, sorry, before the symposium, I would like to call upon our President, Bengal Obstetrics and Gynaecological Society, Dr. Dibyendu Banerjee. Dr. Dibyendu Banerjee will give a presidential address before the second part of our program, that is the symposium and the Bamandash Memorial Oration, and he will formally inaugurate the session by lighting the lamp. Mr. President, Dr. Dibyendu.
Yeah, we are doing a lighting on the lamp. So the traditional lamp is being lit.
Right.
Thank you. I'm sharing the screen. Just give me a minute.
Yeah.
So respected teachers, seniors, colleagues, ladies and gentlemen, it's a pleasure and honor to greet you as the president of your society. Hope you and your family members are well. We are maybe going through the most difficult time in our life. A pandemic in the form of COVID, an economic disaster due to the lockdown, woes of lakhs of migrant laborers, and then strung by the super cyclone Amphan. These few months seem to have changed our lives drastically, hopefully, maybe for the better. Your BOGS has extended a helping hand to our fraternity, mainly junior doctors working in different medical colleges by providing them around 280 PPE kits, 900 N95 masks, and 800 protective goggles. Many of our members have been infected with COVID-19. We wish them all a very speedy recovery. We express our condolences to the family members of the COVID warriors who sacrificed their lives fighting for humanity. As promised, we resumed the stalled election process and completed the elections. The managing committee meeting held on the 23rd of June 2020, after a detailed discussion, requested the present committee to continue till the special general meeting, which was held just today on a digital platform. And it has been decided that the present committee will continue till November, till times improve in November. On 23rd June, we had the 35th Dr. Sujit Chandra Ghosh Memorial Oration delivered by Dr. Dhiman Ganguly, a renowned pulmonologist of Bengal, on pulmonology of pregnancy. Doctors' Day was celebrated by garlanding Dr. B.C. Roy's picture in our office. A blood donation camp was organized along with Rotary Club of Calcutta Kakugachi, and we collected 40 units. 25 of our members who voluntarily donated. I take this opportunity to thank them all. We just had the 62nd Sir Kedarnath Memorial Oration delivered by Professor Tim Draycott, Vice President of RCOG, on assisted vaginal birth in the 21st century. The 84th Foundation Day, as you can see, is being celebrated on the digital platform for the first time in the history of BOGS. And today, we'll have the Foundation Day edition of the BOGS Times to be released later by our Honorary Secretary. The 25th Dr. Bamandash Memorial Foundation Day Oration will be delivered by none other than Dr. Sanjay Gupta, past President of FOXI, on preeclampsia. We shall also have an industrial symposia where Dr. Asa Bakshi from Indore will speak on PCOS, the patient's journey, and our own Dr. Sita Ramamurthy Pal, who will speak on vaccination and pregnancy. And in previous years, we will felicitate 4 senior members who have touched 80 this year. Our team wishes them all a long and healthy life. And they are our own Dr. Kalidas Bokshi, Dr. Bulbul Raichaudhuri, Dr. Bimal Chandra, Bimal Kumar Bhadro, and Dr. Geeta Chaudhary. We are unable to felicitate them personally, but we will send our felicitations across to their respective residences. I am happy to announce that we have been given 1 ICOG point for this program by the ICOG. We shall also be felicitating the rank holders who traditionally are felicitated during the Foundation Day. This year, they are the first prize, that is a prize for the highest marks in GNO obstetrics, in MBBS, goes to Dr. Shankar De. The first prize in DGO goes to Dr. Urmi Mojumdar, and the first prize in MS GNO goes to Dr. Ishba Narzam. These prizes also will be sent over, or they'll be asked to come over to our office to collect the prizes. We are extremely sorry that we could not hand the prizes over to them personally this year. We would also like to thank Biozydus Pharma and GSK for being an integral part of this Foundation Day program. Before ending, I wish you all be safe, be positive, be strong. Long live BOGS, Jai Hind, thank you.
Thank you, Dr. Dibyendu Banerjee. As is customary in this program, we usually have a program of, releasing the BOGS times. And I would request the Secretary of Bengal Obstetrics and Gynaecological Society, Dr. M.M. Samsud Zoha, to do the honors, please. Dr. Zoha will release the BOGS times. Dr. Zoha, Secretary BOGS, are you here?
I would also like to mention that recently in the last month, we had a special edition of BOGS Times on COVID. It is now in an e-version form, but it is a collector's item. And I can assure you, once our times improve and we are ready to post it across, we'll get a printed version for all members, because it is actually so well compiled by our website committee, publication and the website committee. It should be a collector's item, and we will shortly be distributing it to all our members.
Yeah.
Amit, we can go ahead with our next session, that is the symposium. Zoha can join in later for the release of the times. Please go ahead with the symposium.
So as we go ahead, we have a symposium where, as the president announced, we have 2 speakers, Dr. Sita Ramamurthy Pal and Dr. Asha Bakshi.
I think Zoha is here, I believe.
Who will be
Zoha,
introduced?
are you here? Zoha, are you here? No, then go ahead.
Who will be introduced by our chairpersons. So it will be my pleasant duty to welcome the chairpersons of the symposium. I invite Dr. Bhaskar Pal, Senior Consultant Gynecologist of Apollo Gleneagles Hospital. He is also the Honorary Secretary of IAGE. He is the Chair, AICC RCOG East Zone, and also President-elect of Bengal Obstetrics and Gynaecological Society. Dr. Bhaskar Pal, and the other chairperson, Dr. Shamal Sheth. He's a senior practicing gynecologist of Kolkata. He is the Senior Vice President of Bengal Obstetrics and Gynaecological Society, and he's also the past chairperson of MTP Committee of FOGSI, Dr. Shamal Sheth. So I would request both of you to conduct the symposium, sir.
Thank you, Dr. Basu. Welcome everyone to this very unusual Foundation Day celebration. And I think for every one of us, this is the first time we are seeing a Foundation Day being observed on the virtual platform. Of course, we couldn't have a full Foundation Day and couldn't do the short paper sessions and the debate sessions for the postgraduate trainees. But anyway, thank God that we've managed to have the oration and a symposium and a wonderful oration in memory of Dr. Sir Kedarnath Das. May I request Dr. Shamal Sheth to introduce the first speaker? I can't see Dr. Shamal Sheth here.
Can you do the honors, Bhaskar?
Yeah, sure I can.
Tim has to leave. He's gave the message.
Yeah.
You can excuse him and then we'll move on.
Thank you. Thank you, Tim. Thank you. It is my pleasure to introduce Dr. Sita Ramamurthy Pal, who is a consultant obstetrician and fetal medicine specialist at Apollo Gleneagles Hospital, Kolkata. And he is also a member of the managing committee of the Bengal Obstetrics and Gynaecological Society. And she'll be speaking on vaccination in women. And this lecture is sponsored by GSK Biologicals Limited. Sita, would you please share your screen?
Yeah, thank you. Thank you for the kind introduction, and thank you, President and Secretary, for giving me this opportunity to speak in this prestigious Foundation Day. Though it's on a virtual platform, I think we connect better. We feel still together and as one, celebrating this. So I'll be specifically speaking on vaccination in women, and I'm sharing my screen. Is it visible?
Yes, it is.
Thank you. So not restricting to vaccination in pregnancy, I'm going to be talking about vaccination for women in general, with all the issues that stand before us in this present pandemic. So vaccination for women, as for anybody else, what is its importance and what are the recommendations? And I would acknowledge GSK here for providing me the slides here, though with some modifications which I have done, because this is a GSK sponsored session. So the importance of vaccination, obviously, as we know, is to reduce diseases, the disability, death, and inequity worldwide. And what better time than we know now to understand the importance of vaccination, because all of us are eagerly waiting as to when we would have a vaccine in hands and be safe to go out without any masks and social distancing. So we have a vaccine would control morbidity, mortality, and associated complications that would be there with a preventable disease that we're looking at. It would eradicate and eliminate diseases where India has seen that by achieving the elimination of maternal and neonatal tetanus by improving access to immunization. There is prevention of infection, and what better by the evidence that we have by the human papillomavirus vaccine that's come up in a big way. It protects against related diseases, especially measles vaccination, which has multiple complications, bacterial pneumonia and malnutrition, and even other benefits it has in the society. In fact, in India, the introduction of childhood rotavirus vaccination is projected to save nearly about rupees 150 crores in the treatment cost per year. And with the mission Indradhanush, which was initially launched in 2015 to immunize all children and pregnant women, the target was to cover 90% by 2020, which we don't know if we'll achieve, but we will be there eventually. So why do we need to vaccinate women? Obviously, it helps in improving the women's health in general, because she's the pivotal role. And if anybody would say that if she has the power in hand, the whole country will improve. Vaccination before, during, and after pregnancy, it helps to protect the woman from maternal morbidity and mortality related to serious infections that can happen in pregnancy or otherwise, and destroy the family as a whole. And it not only protects the mother when you give the lady when she's pregnant, but also provides immunity to the young infants. Now, generally, vaccination was always considered the purview of the pediatricians in the childhood and the physicians in the adult context. But we do have a role, and a big role now. And studies have clearly shown that gynecologists almost recommend, coming directly from gynecologists, the vaccine acceptance is almost about 5 to 50 folds higher. So we do have an important role here to play, and it is very obviously seen as when we counsel these women and the acceptance, because the bonding that we have with them during their adolescence or during their pregnancy goes a long way for them to accept what we say. Okay. So what is the disease we're going to be talking about today and its prevention? It's mainly the main role of tetanus, diphtheria, and pertussis vaccine that's come up a big way in pregnancy, measles, rubella, and mumps, to some extent chickenpox, cervical cancer, and mainly influenza. So what about tetanus, diphtheria, and pertussis, that is the Tdap vaccination for women? Now, Tdap vaccination during pregnancy, it has its very obvious benefits. Basically, it is to boost the maternal antibodies, aiming to provide protection to the pregnant woman and the fetus that persists until the baby can be immunized. This is very important, and I'll explain to you why. As it is, we know we are giving immunizations to these pregnant women, but there is some extent to where the baby has to wait for it to be immunized, and that is what this Tdap vaccination is going to cover. So it protects both the mother and fetus during pregnancy, as well as protects the newborn in the immediate weeks after birth. So we all know that maternal antibodies are actively transported across the placenta, and it provides passive immunity to the neonate before he or she can be vaccinated. And years to come, we have seen that several vaccines have been time tested, which are generally well tolerated and immunogenic in pregnant women and their neonates. Some vaccines are routinely recommended. We've always been referring tetanus vaccine and flu vaccine, but now what is new, well, not very new, but in the box is in our armamentarium is the Tdap, that is pertussis booster vaccine. So with the Tdap vaccination in vogue, a lot of global and local bodies are recommending strongly this vaccination during pregnancy. In fact, if you see the ACOG statement says that it should be administered to all pregnant women as early as 27 to 36 weeks. The Royal College recommends to receive a dose of Tdap during each pregnancy, which should be administered from 27 to through 36 weeks, regardless of the previous receipt. WHO also has said in 2015 that vaccination is likely to be one of the most cost-effective strategies for preventing disease in infants. FOXI, in their guideline in 2016, has said that Tdap should be administered during pregnancy in order to provide optimal protection to the baby during the first months of life. And IAP in 2016 has said 1 dose of Tdap vaccine to the pregnant women or adolescents during each pregnancy, again during 27 through 36 weeks of gestation, regardless of the number of years from prior tetanus or Tdap vaccination. So it's very clear that all the global bodies and the national bodies are recommending Tdap, and we will see why the pertussis has been added to it. Because pertussis is a highly contagious respiratory infection and is caused by the gram-negative bacterium Vertitella pertussis. And in a immune-naive population, 1 primary case of pertussis can cause 12 to 17 new cases. And pertussis affects people of all ages. But most importantly, the babies which are affected, then it becomes very severe. And a study which showed that India is the top country by leading in for number of pertussis cases in the world. It shows the peak in 2009, and that's when the recommendations, and everywhere across the world they felt that we need to implement something which would protect these babies immediately after birth. And why so? As I said, because the current recommendations for DTP vaccination in the pediatric group is basically the first dose is not recommended until 6 to 8 weeks of age. So in the first 2 months of their birth, these infants are not protected. And when they are not protected, they're more susceptible to infection, and they are have their associated complications in death if they do have an infection. That is, more than 90% of infants under 2 months of age require hospitalization, and more than around 75% of the pertussis-related deaths occur in infants under 3 months of age. And the most common here, without their knowledge, as we now know about these asymptomatic carriers of COVID, mothers, similarly with pertussis, mothers are the most common source of pertussis infection for these newborns. And as you can see here, and this is why those infants are at very high risk, especially in their first 2 months of life when they don't have any protection, because we are not allowed, or should not be giving the DTP vaccination to these infants until they are 2 months of age. So vaccine strategies which may help protect young infants and pertussis is you give an adolescent a booster vaccination, either by cocooning or maternal immunization, as we have seen, which is very, very effective and in protecting these infants from pertussis. So Tdap vaccines have proven to be effective. As I said, in many countries, they have been used as global recommendations. In Spain, Argentina, Australia, all of them have recommended, and they have all said that there's absolutely safe to be used in pregnancy. There is no increased risk of any pre-specified maternal outcomes within 42 days of vaccination. It does not lead to excessive pregnancy-related morbidity, even with repeating dose in serial pregnancy. So it's very, very safe. And they have also demonstrated a very suitable safety profile. So considering all the studies that have done, it's, I think, mandatory now to give a Tdap vaccination during pregnancy. And more than 30 countries recommend these pertussis vaccination for pregnant women, including India. So in summary, which we have the Boostrix vaccine, it offers triple protection against diphtheria, tetanus, and pertussis for the Tdap vaccine. It offers protection to both the mother and the newborn, especially in its first 2 months, against serious diseases and complications, as we have seen. And global and local bodies, including FOXI, have strongly recommended Tdap vaccination during pregnancy. So coming to measles, mumps, and rubella vaccination, we all know MMR by itself has its complications. Measles, it can lead to increased rates of premature labor, spontaneous abortion. Mumps though it's mild symptomatically, it can lead to an increased risk of fetal death. But the main concern is rubella, where infected adults, as we know, especially women, they might be mildly symptomatic or less symptomatic. But if they develop infection and infect the fetus can be affected by a congenital rubella syndrome. And congenital rubella syndrome has its own series of complications, that is, especially when the infection occurs in the early stages of pregnancy. It can spread from the placenta, enters the viral circulation, and the baby has a lot of complications, especially heart defects, microcephaly, cataracts, mental retardation. But the most important is hearing impairment, and that is something we cannot detect on ultrasound. Though all the latest guidelines that have come for diagnosing these infections in pregnancy, hearing impairment is something that cannot be predicted, and that is why it is so important to protect these women against them having a congenital rubella baby at hand and having this baby with a lifelong disability. So MMR vaccine, that's why it's been recommended to add the measles and mumps along with the rubella. So it's 2 doses, 4 weeks apart for all women or older than 12 months, girls, recommended by the following bodies. And for the adult, CDC emphasizes use on the use of combined MMR vaccine for any indication. It has, because as I said, it adds the potential benefit of adding, again, protection against measles and mumps. And usually you don't need to require any antibody testing before vaccination, but as we all know, the pregnancy should be avoided within 3 months of vaccination. So ideally, these women, if they are seen prenatally or during a prenatal counseling, should be inquired about rubella. And if they have not had the vaccination, you don't need to do antibody testing. You can just go ahead and give the MMR vaccine. Chickenpox, though rare in pregnancy, but it is quite common in our Southeast Asian population, but it's highly contagious herpes virus, and it enters the host through the upper respiratory tract or the conjunctiva, and the peak incidence is during winter in its coolest or driest months. And as we all know, the incidence of maternal fetal varicella syndrome is around 2%, occurring mainly in the first and second trimester. But in the later stages, the mother has a increased risk of complications, like leading to maternal pneumonia. And if the varicella infection occurs during the first and second trimester, as I said, there is before 20 weeks, there is a 2% risk of congenital varicella syndrome. And newborns who develop chickenpox from 5 days before to 2 days before delivery are also at risk of developing neonatal varicella syndrome. So chickenpox, as I said, is most common in adolescents and adults. And globally, there is recommendation. Even Foxy recommends local vaccination for chickenpox. Again, it's given 2 doses, 4 to 8 weeks apart for all older than 12 months, which is recommended by CDC, Foxy, and the Indian Association of Pediatrics. So ideally, again, for chickenpox, you must screen them in the preconceptional period. They should be screened for varicella immunity by taking a history or vaccination by serology. Serology screening of serum for IgG antibodies is used to assess immunity, and all the non-immune women should be vaccinated and counseled to avoid pregnancy at least for a month following chickenpox vaccination. What about HPV vaccination? I don't need to say much about this. We all are very aware as what important role it has in preventing cervical cancer. Why? Because serious complications from HPV vaccination can happen, including CA cervix, CA vagina, vulva. HPV vaccination prevents more than just cervical cancer. And widespread HPV vaccination has the potential to reduce cervical cancer incidence around the world almost by around 90%. And the statistics we all know in India, especially leading with cervical cancer, almost 1 out of 4 women who die with cervical cancer. So the prevention strategies, as we know, is screening, but vaccination is not an alternative, is complement. So you have to continue your screening and also give vaccination. And vaccination induces higher antibodies in the blood and site of infection. And these antibodies actually neutralize the virus and prevent entry into the cells. So the recommendations for HPV vaccination is for WHO is 9 to 13 years, you require 2 doses, 14 years and above, you require 3 doses. Similarly, Foxy also recommends that we have 9 to 14 years, you require only 2 doses, but 15 to 45, you can give it up to the age of 45, you have 3 doses, 0, 1 or 2 or 6 months, a catch-up dose. With influenza, we know that both influenza A and B viruses, both are very important respiratory pathogens. Influenza occurs all over the world, and the annual global attack rate is estimated around 5 to 10% in adults and 20 to 30% in children. Most of the infections are caused by influenza A, that's H1N1, influenza A, H3N2, and influenza B viruses. And it's basically the antigenic drift that results in seasonal epidemics, and due to point mutations that are occurring in these viral replications. So as of now, for influenza, we have 2 kinds of available vaccines, the inactivated vaccine and the live attenuated vaccine. The former can be trivalent, consisting of 2 influenza strains, and the 1 influenza B strain, either of them, or the quadrivalent, which has 2 of A and 2 of B strains. So inactivated vaccine specifically is recommended in pregnancy from 26 weeks onwards, and it goes a long way in protecting these women, as we are seeing a lot of women who develop a flu-like illness in pregnancy to start off with, but it can become very severe and have complications leading premature delivery, and then the lady going into multi-organ failure. So inactivated vaccine is recommended from 26 weeks onwards. It can be given in any trimester, and in fact can be given up to 2 weeks postpartum as well. And in the case of a pandemic, the vaccine can be given earlier to protect the mother. And a retrospective analysis of a 5-year data showed that influenza vaccination was not associated with any rise in major congenital malformations, and in fact was associated with a reduction in the overall stillbirth rate. If you have to consider adult women who are getting vaccinated for influenza, depending on the strain that comes up every year during the September month, 1 annual dose is recommended for our elderly population. Pneumococcal vaccine is also recommended for our elderly population, 1 dose, which is actually a lifelong protective immunity it has. So in putting all in one, we have the Foxy recommendations, which came up in August 2014, where they said, as we go along from adolescent to menopause, the adolescent age group, you have typhoid, cholera, which can be given seasonally. Rubella, you must target these women, young girls, and give them rubella vaccination. HPV would be the ideal time for these young girls to have. And again, an MMR catch-up vaccination recommended from 11 years onwards. As part of pre-pregnancy or prenatal counseling, you would give them rubella, hepatitis B, varicella. Of course, if you give them, you have to defer the pregnancy for 3 months. And if you give during pregnancy, as I said, the Tdap coming in a big way, 2 doses of tetanus commencing from 2nd trimester, but you have to consider Tdap instead of the 2nd dose of tetanus, and give them from any time from 26 weeks onwards. The regular, obviously, pertussis vaccine is contraindicated. That's why we give the Tdap for all the benefits that we have seen. And influenza vaccine, again recommended from 26 weeks onwards. It also can be given earlier in a case of a pandemic. Postnatal, for catch-up vaccinations, if the lady has missed her vaccinations prenatally, then you can catch up on these women for rubella, hepatitis, tetanus, and including HPV vaccination. And the adults and elderly women, if they are below 45, you can still consider them for HPV. And I would strongly recommend the influenza vaccine and the pneumococcal vaccine. The IAP also has recommended the same in August 2016 with its recommendations for Tdap and human papilloma virus, and the ACOG and CDC recommendations in 2018 suggesting the same as to different types of vaccines that are available, the influenza during flu season, Tdap during each pregnancy, the pneumococcal, HPV through 26 years of before pregnancy and after pregnancy, MMR, and varicella, of course, when they are given, you avoid conception for 4 weeks after the vaccine. So as I said, we are moving from the pediatricians and adults to giving our vaccines ourselves. So we must know some basic facts about the vaccine, that we need to store these vaccines between, 4 to 20%. And vaccine should be placed in the middle shelves of the refrigerator and never be exposed to freezing temperature, because the vaccine effectiveness can be decreased by exposure to light. But a very important thing that we miss in all this is to improve our communication and talk to these patients about the importance of having vaccines at the right time. So you have to listen to their queries, take time to listen to them, solicit and welcome all the questions in hand, and keep the conversation going, because education regarding vaccination is more important than education regarding disease. I think if you can convince them about the benefits and the importance of having vaccination at the proper time, including the girl and the mother when she comes along with her, the pregnant lady and the family, that goes a long way in protecting our women from all the diseases that we have in hand. So I thank you for your patient hearing, and with all the hope that we will have a vaccine for our COVID-2 as early as possible from India. Thank you.
Thank you very much, Sita. I think you have covered every at any age group. It's fine one. I think we'll be taking up the questions at the end of the session. Now, our next speaker is Dr. Asha Bakshi, and she is the organizing chair of AICOG 2020 on Indore, and she is the aspiring candidate of VP Foxy from the South Zone. Now, without wasting any more time, I think we should call Dr. Asha Bakshi.
Shamal.
Yes.
Yeah, she's the aspiring VP candidate from the West Zone, not South Zone.
I told South.
Yeah.
I told South. Oh, then I'm sorry. She's obviously from West Zone. Yes, I beg your pardon. And so, Dr. Asha Bakshi, please, you can start your discussion straight away.
Yeah, Asha is a close friend of ours. She's a very senior gynecologist and infertility specialist at Indore. She's the past president of Indore Society. She's been a fellow representative on the West Zone RCOG India Representative Committee. And Asha, all the best for your elections. And we would like to hear from you on PCOS, a patient's journey. Please, this lecture is sponsored by Bayer-Zydus Pharmaceuticals.
Thank you very much for inviting me. Thank you, Bhaskar. Thank you, Dr. Sam. Thank you, Dr. Seth, for inviting me to Bengal Obstetric Gynaecological Society celebrate 84th Foundation Day celebration. And a very happy World IVF Day to all of you. Today, I'm going to talk on PCOS, the patient's journey. And we all have seen PCOS patients ranging from adolescents to almost perimenopausal age. So it is one of the most common endocrine disorder of reproductive age group, leading to infertility, prevalent in 18% of Indian women. And insulin resistance affects 75% of lean women and 95% overweight women. This is further aggravated by weight gain, metabolic, and psychiatric problem. And you will see that reproductive disorders are more common in the younger age, and metabolic disorders are added as the woman gets older. So, and whenever we deal with these patients, all sorts of problems, right from menstrual problems to hirsutism, contraception problems, sexual health, infertility, all these problems are there. And in the older age, the pregnancy-related complications, quality of life, type 2 diabetes, cardiovascular disease, and risk of cancer. So these patients are seen by doctors from different specialties. And whenever we have to deal with these patients, sometimes we need a multidisciplinary approach as well. And we all know that many of the PCOS patients, they develop anovulation, and that is because of the supraphysiological synthesis of estrogen, which has negative feedback effect on hypothalamus and pituitary, and therefore anovulation occurs. Now, establishing the diagnosis of PCOS, basically Rotterdam criteria have been laid down by a combined meeting of ESHRE and ASRM, and it includes oligoanovulation, androgen axis, polycystic ovarian morphology, and 2 out of the 3 criteria have to be present, and all the other causes of hyperandrogenism and ovulatory dysfunction have to be included. So we have to consider a differential diagnosis as well when we are thinking about PCOS. And international evidence-based guidelines have been assessed in 2018, and they have modified few things about the diagnosis also. So coming to the adolescents, PCOS prevalence in Indian girls is almost 9 to 13%, and 36% in a study were found to be having PCOS. Now, clinical profile is, especially in the youngsters, is typical this 15 years old obese girl with hirsutism, acne, altered irregular periods. So that all really affects her. And it's very, very important that these patients are dealt with sincerity, empathy, and we have to encourage these patients and give them sufficient time, because they not only have these problems, sometimes this all affects them psychologically also. So typical good examination has to be done, keeping PCOS in mind as well. And especially if they've got hirsutism, then it is always a good idea to make this chart and do the scoring as per Ferriman-Galway index. And initially, the score was thought to be 8 and above, but in the ESHRE guidelines now it has been modified, and it has been considered as anything above 4 to 6. So that is a change that has occurred in recent ESHRE guidelines. Again, whenever they tend to have, adolescents as such tend to have acne. So you see how the acne are and how severe they are. And usually moderate to severe, they leave the scarring, and that is really bad, because that is going to affect this girl for lifelong. And young girls are very particular about their skin, so that has to be really looked into, and pictures have to be taken so that you can compare them for monitoring. Now, acanthosis nigricans, we should really look for acanthosis nigricans even in young girls, because even you can see this on young girls of 15, 16. I've diagnosed diabetes in such cases. So it's very important that when the girl is sitting, then have a look at her and check for acanthosis nigricans. Depression. Many women, many of these girls, they tend to have depression. So it's very important to be sensitive towards this, and proper questions should be asked and screening should be done. And there are many PCOS quality of life tools available, and they can be used. And if depression is suspected, then proper counseling should be done by the psychologist. Now, whenever you diagnose, especially in adolescent, it is not necessary that there should be ultrasound criteria. If there are irregular cycles and signs of hyperandrogenism, then that is sufficient for the diagnosis. But if only one of these is available, then maybe you can use ultrasound criteria. But again, ultrasound criteria is to be used only in women, only in girls who have had their menarche and are post 8 years post their menarche. Then ultrasound criteria apply to these young girls for the diagnosis of PCOS. Now, important points to be considered in diagnosis of PCOS in adolescents, that they tend to have functional ovarian cysts, why ultrasound is not so good in picking up PCOS in adolescents, because they tend to have functional ovarian cysts. Transabdominal ultrasound may be incorrect. Transrectal, I wouldn't want anybody to undergo transrectal ultrasound. Acne as such is common during this time. Obesity, insulin resistance, and hyperinsulinemia, though common finding in adolescents with hyperandrogenism, are not the only basis for the diagnosis of PCOS in adolescent girls. So these are certain points of confusion in case of PCOS. The incidence of metabolic syndrome in PCOS patients in adults is not less. 54.9 adolescents with PCOS have been found to be overweight, and 25% have metabolic syndrome. So this is what we have to look for. And when we are suspecting metabolic syndrome, then we have to check the blood glucose, HDL cholesterol, triglycerides, check for obesity, and check for the blood pressure. Now, counseling, as I said, is very, very important. We have to give sufficient time and communicate with the patient, because there may be behavioral problems, abnormal eating problems, damaged self-confidence due to acne, hirsutism, and obesity, and increased level of anxiety and depression. So, and very important to discuss lifestyle intervention, diet, and exercise. Prevention of weight gain is again important, and in adolescents, encourage them at least 60 minutes of moderate to vigorous intensity physical activity, including those that strengthen muscle and bone, at least 3 times a week. And what happens, typically these girls are in their career formative years also, especially after the class 9th, and they are sitting and studying. So I think these are the girls who should be really encouraged to do some sort of exercise, and that way the things up to some level, the PCOS may be controlled. Then weight loss, we all know, is associated with metabolic changes as well as improvement in the menstrual function. Exercise, best exercise regime is not known, but many types of exercises have been advised in the literature and advised by different instructors also. And similarly for optimum diet also, we do not know what is the optimum diet, but we all know that the diet should be restricted in carbohydrates, and the diet should have low glycemic index. And the aim is to achieve at least a 5% weight loss and even more. And recently this ketogenic diet for PCOS is getting very popular, and it has been found to be quite effective. So, and there are lots of apps available, and we can encourage the youngsters to go through this, and maybe that these modern things will help them to reduce the weight. Now, metformin can be used along with oral contraceptive and lifestyle modification, and that can reduce central adiposity, reduce total testosterone, increase HDL, and overall, sometimes weight reduction may be possible, but usually it has been found that this on itself will not reduce the weight. A good lifestyle modification will be required. Now, if the girl has got cutaneous hyperandrogenism, signs of cutaneous hyperandrogenism, then goal of the hormone therapy is to decrease the androgen production, serum free androgen levels, and block androgen action at the level of target organs. So 201 ASRM guidelines, they suggest that combined oral contraceptive can be used. And even Indian guidelines, they suggest low dose oral contraceptive pill and with anti-androgenic progestogens. Cyproterone acetate can be used, and topical medications can be used along with pharmacological therapy. Now, AMH is one thing, though we tend to do AMH, but still it should not be used as an alternative for detection of PCOS as a single test. But somehow it can help us in association of signs and symptoms of PCOS, restoration of ovulation in aging PCOS, predicting menstrual response after weight loss, and predict CC non-responsiveness, therefore modification of the dose. So AMH can help us up to some extent in the treatment and management, but still guidelines are not there about using AMH as a diagnostic tool. Now coming to infertility, this girl has now grown up, she is married and she's planning to conceive. She has been trying since 3 years. So she had lost, usually typically Indian girls, they lose a lot of weight at the time of marriage, but now she has regained it. Otherwise, everything is normal with her. So what to do? I think preconception care here is very important. And we have to tell her that the modifiable factors which will affect her fertility are excessive weight, the waist-hip ratio. So all those things really need to be taken into account, and she should again start losing weight along with naturally other measures. We can't just wait for her to lose weight, but along with other measures, the weight loss will help. Then smoking, alcohol, recreational drugs, etc. are to be avoided. And if there are sexually transmitted diseases, they have to be treated. Nutritional deficiencies, I think that is again one very important thing. Deficiency of vitamin D and B12 is very prevalent. So that should be corrected. And psychological factors affecting sexual intimacy will end if she is undergoing, if she is to undergo ART treatment, then again their counseling will be required. Now, fertility and pregnancy problems specific to PCOS will be GDM, preeclampsia, miscarriage, stillbirth, longer time to conception, poor embryo development, decreased implantation, ovarian hyperstimulation, ectopic pregnancy. So all these things need to be kept in mind. And lifestyle management, as I've already discussed, is a very, very important thing, which will affect not the physical well-being, but also the emotional well-being. And then you can start her getting ovulated with the help of oral ovulagens, which may be clomiphene citrate or letrozole or insulin sensitizers. These days, letrozole has become the first line of medication. So about the clomiphene, and routine protocol is to use letrozole from 2nd to 6th day or 3rd to 7th day. But when she is not responding, then in that case, you can use a stair-step protocol, or you can use combine gonadotropins with letrozole, or you can use letrozole step-up protocol, or so all these protocols can be used to get a good result. And as compared to letrozole, letrozole is considered nowadays first line of pharmacological therapy because it has been associated with monofollicular development. So chances of twin pregnancy are also very less. Now, gonadotropins can be used as a second line pharmacological agent, especially when there has been a CC resistance or a letrozole resistance. Now, gonadotropins, whenever you start, should be started with a very, very low dose, and then you can step up. Now, role of laparoscopic ovarian drilling. In this particular guideline, 2018 guideline, they have really talked a lot about laparoscopic ovarian drilling, though it is a less invasive modification of wedge resection, but again, it is invasive. It is the main indication being letrozole resistant PCOS. And it can be done as a, usually it is done for CC resistant patients, but sometimes they have mentioned that it can be done as first line if laparoscopy is being done for some other indication. So this is again a question. Long-term data has not shown any increase of premature ovarian failure. We are always scared of premature ovarian failure after ovarian drilling. But I think this is where people are sensible and they are doing with needle point diathermy, and particular that using the formula of 4 and not destroying a lot of tissue, then I think the incidence of premature ovarian failure will not increase. But I have seen people doing ovarian drilling using the hook which they use for lap choline. So I think that's the reason this has to be discouraged. Now, advantages of laparoscopic ovarian surgery can achieve unifollicular ovulation with no risk of ovarian hyperstimulation and multiple pregnancy. And intensive monitoring is not required. And treatment is best suited for those whom frequent ultrasound monitoring is not possible. Somebody is living in the village or far off. So once you have done, then you can ask her to try for pregnancy for quite some time. Now, IVF is done in women where these things have failed, and the advantage of IVF can be really that you can avoid multiple pregnancy in these patients if you are using a single embryo transfer. And they have to be counseled whenever you are doing about the increased chances of ovarian hyperstimulation and multiple pregnancy if you are not going to do single embryo transfer. The which gonadotropin can be used, any gonadotropin can be used, urinary or recombinant, and there isn't much role of recombinant LH in these patients. Now, agonist versus antagonist, I think most of us have switched over to antagonist, especially in PCOS patient, because it is associated with less incidence of ovarian hyperstimulation. And what should be the starting dose of gonadotropin? It should be started with minimum dose, and there is a good algorithm which one can use, keeping in mind the age, the AMH levels, and any previous response. And based on that, you can really decide the starting dose. Now, trigger HCG is if you use it at lowest dose. Otherwise, you can use GnRH analog, especially when you are planning to freeze all the cycles. So if you're using long protocol, the GnRH analog protocol, then this is a very good paper about sliding scale HCG trigger. And here they have given all the values on which what dose of HCG is to be given. And I find this particular chart very, very helpful. Now, use of metformin as an adjunct for IVF can be used, especially because it has been associated with reduction in the risk of OHSS. Any role of pre-treatment with OCPIL? Usually people say that OCPIL should not be used because it is associated with reduced IVF success rates. But in this particular study, they have found that if you are using long GnRH analog, then incidence of severe OHSS was significantly decreased. But most of us have shifted to antagonist protocol. And even for antagonist protocol, if you are using OCP treatment, then the pill-free days have to be more than 7 days. And this was suggested in ASHRI 2018 by Christopher Blockade. Now, whenever you are doing stimulation for these patients, you have to take all these measures to prevent the OHSS, because biggest risk here is OHSS. And if you really want to be OHSS risk-free, then consider freeze all policy that would really prevent OHSS. Now, PCOS can occur in this whole thing goes up to the perimenopausal age also, and poor thing, one or the other is. Only one thing which is not one positive point about PCOS that I found in the literature was they are not associated with higher risk of osteoporosis. Otherwise, there are all sorts of problems. They tend to have menorrhagia. So this girl is now 45 years old. She's having menorrhagia. The uterus is adenomyosis, endometrial thickness is 24 millimeter, and bilateral ovaries. Now, this PCOS picture starts getting a bit lesser as the woman ages. So hysteroscopy guided biopsy was done, and it was complex hyperplasia without atypia. And ultimately, she underwent total laparoscopic hysterectomy. So what are the long-term implications of PCOS? There may be cardiovascular diseases, type 2 diabetes, obstructive sleep apnea. This is something which people don't, awareness about this problem is quite less, and endometrial carcinoma. So women with about diabetes, women are almost 4 times at risk of developing diabetes, and diagnosis is also 4 years earlier. So it's very, very important that we sensitize these women. Even if she had gestational diabetes, she's going home, and then in postpartum advice, I think we should advise her that she should have GTT in the postpartum period, and overall also regularly she should keep on checking her HbA1c or her glucose levels. Now, about the cardiovascular disease, again, she is at a risk, and a proper monitoring should be done for cardiovascular diseases. obstructive sleep apnea appears to be more common in PCOS and in obesity. So it is a common corollary of PCOS, and it has again significant other metabolic effects. Then risk of endometrial carcinoma is also quite high in patients with PCOS. So we have to keep a track even afterwards. So there is 2 to 6 fold increased risk of endometrial carcinoma, and optimal prevention of endometrial hyperplasia and cancer should include combined OC pill and progestin pill in those with cycles longer than 90 days. So that's what is recommended, that even if a woman has prolonged cycles, then at least she should have 4 bleeds in a year. So I think that is a very important thing. So my conclusion is management of PCOS requires multidisciplinary approach. Preconception care and lifestyle management have a key role. Letrozole is the first drug of choice. Laparoscopic ovarian drilling, if used judiciously, does have a role. While using gonadotropins, all measures should be taken to prevent ovarian hyperstimulation. And whatever said and done, when you are dealing with amenorrhea in a woman with PCOS, please first rule out pregnancy, rule out malignancy, and then treat her further. So I would like to thank you a lot for the patient here listening. And I would like you to support me for my candidature for Vice President, Foxy West Zone. And I'm sure that we would be able to do AICOG next year, though it has been postponed a little bit. We will do it in original flavor, and I would be looking forward to see you all in large numbers. Thank you very much for giving me this opportunity, and thanks a lot.
Thank you very much.
Thanks.
Hello.
Yeah.
Yeah, thank you very much. It was a nice on PCOS. You know, PCOS is a very burning topic, and we all gynecologists are coming across few patients at least daily, and we are yet to find out a solution to treat PCOS effectively for and uniformly for different girls. Thank you very much. We are enriched with your deliberations. Thank you very much, Dr. Asha Boksi, and wishing all the best for your ensuing elections. Thank you.
Thank you, Asha.
Thanks.
Thank you very much. May I hand it over back to our masters of the ceremony today, Dr. Amit Basu and Dr. Tulika Jha. Thank you very much for giving us the opportunity to chair this session on the Foundation Day.
Thank you, Bhaskar, for making up when I was not there. So can we take the questions? Is there any question at all, Amita?
Yeah, we've got time for questions. If
Jay, are there any questions?
No, sir.
So fantastic.
There is no question.
We can release the BOGS times now. We have time.
Yeah.
Shall we?
Yeah, I request the Honorary Secretary of the Bengal Obstetric and Gynaecological Society, Dr. Zoha, to release our Foundation Day edition of BOGS Times.
Thank you, President. Let me see. Yes, this is the Foundation Day issue of the Bengal Obstetric and Gynaecological Society's Times. We call it BOGS Times, the mouthpiece of Bengal Society. It's unprecedented that the website and the bulletin committee has prepared this 24 pages BOGS Times in record time of 1 month, because we had an emergency e-edition, special edition, that is COVID edition of BOGS Times just 1 month back, and we did not give them time. We said we have to be ready by Foundation Day, because Foundation Day edition, and there is the edition, and appropriately the editorial is on telemedicine in current obstetrics and gynecological practice, written by our own Basav Mukherjee. And like every other issue in this year, we have something called District Corner, where people from people who are not member of BOGS and other societies member in Bengal and from different districts. They write, and this time Dr. Dipanita Sen from Durgapur has written again on corona in Durgapur. We have a section called Up Close and Personal, and this time this Up Close and Personal is on none other than our very own senior member of the managing committee, Dr. Bulbul Rai Chaudhary, very close to all of us in the BOGS. Dr. Amit Basu, Dr. Basu Mukherjee, Dr. Tulika Jha took her interview. That is, I request all the members to go through it. You will get this edition of BOGS Times online. All members will be sent by mail, and you can also get it from BOGS website, because physical edition is not possible in this pandemic time. And another important thing is the BOGS Foxy prizes. We under the leadership of Dr. Sudhir Adhikari and Dr. Basu Mukherjee, we got 4 trophies last year and Lucknow EICAG. So this is a picture of when we received those awards from Lucknow. My heartiest congratulations to Dr. Sudhir Adhikari and Dr. Basu Mukherjee and the entire team of 1819 for the excellent work they did. This is our signature event, annual conference, the BoxCon 45. They're all glimpses. We had a very nice master class on fetal medicine, male infertility. And these are all glimpses of our annual conference. So,
I think Zohada is having some technical glitches.
Internet issues.
Internet issues, maybe. Huh?
No, we can't hear you. Your internet is gone.
It will come back. Actually, it's fluctuating.
We took two things. One is for the PP for junior doctors.
Creating a problem.
Can we go forward?
No, we can't. You're sharing a screen.
Oh.
For the whole effort, I need to take few names, especially 3 names who tirelessly managed to.
Wow, we can't hear you. Please correct your connection.
No. No.
Good afternoon. আমায় শোনা যাচ্ছে? হ্যাঁ, ভালো আছি।
I think, Dibyendu, I think you can take over from him because he can't unmute
Dibyendu,
yourself.
You have to unmute first.
He has to stop
sharing.
screening.
Right.
Tell him, give him a
Jay?
message.
Sharing.
Yeah.
Yeah. Okay. Carry on.
Now,
Sorry about
now
this.
it's okay.
No, but then I think
Let's
that
finish,
you will all
yeah.
get the BOGS. Am I audible now?
Yeah.
Yes. Yeah. Very clearly.
Yeah, I think you all get this BOGS times by your mail, and you can get it from our website. I was mentioning 3 names who worked tirelessly to make it happen: Dr. Chaitali Dr. Roy, Dr. Susmita Chattopadhyay, and of course, on top of them is Dr. Shukanta Misra. And on behalf of the entire managing committee, I express my profuse thanks for them. Thank you very much. This is a lovely BOGS times, and I'm sure you'll all enjoy it. Over to Tulika.
Thank you.
Amita.
Thank you. Thank you, Dr. Samsud Zoha. But it will be incomplete if I do not thank the previous speakers, Dr. Sitaram Palmurthy and Dr. Asha Bakshi, and the chairpersons, Dr. Bhaskar Pal and Dr. Shamal Sheth, for conducting the excellent symposium. Well, to carry on the program, to carry the program ahead, I would like to invite Dr. Tulika Jha, Joint Clinical Secretary, to take the program ahead. Over to Tulika.
Thank you, Amita. We now move on to the next part of the Foundation Day program, the prestigious Bamandas Mukherjee Memorial Oration. This oration is also held in memory of a great obstetrician and gynecologist, Dr. Bamandas Mukherjee. This is the 25th edition. So 2020 is the silver jubilee of this important event of our BOGS calendar. Over the years, over these past 25 years, we have heard some fantastic orators on this Foundation Day. And today as well, we are privileged to have amongst us a wonderful speaker, Dr. Sanjay Gupta. But before we hear him speak, I invite our President, Dr. Dibyendu Banerjee, and our Secretary, Dr. M.M. Samsud Zoha, to chair the session, the prestigious 25th Bamandas Mukherjee, Dr. Bamandas Mukherjee Memorial Oration Session. And so over to you, Dibyenduda and Zohada. Please, would you be on screen?
Yeah. Thank you, Tulika. Just a minute.
Slideshow.
I welcome you all. I welcome you all to the 25th Dr. Bamandas Memorial Oration, which is also the Foundation Day Memorial Oration. As we all know, due to trying circumstances, this is the first time that we are having this oration on a digital platform. And sadly, it's the 25th oration. But we are privileged to have Dr. Sanjay Gupta, the Secretary General of Organization Justices. Dr. Gupta has also been the past president of FOXI, and he's a very well-known Foxian. He's very well known to us. He's an excellent orator. We are blessed to have him, and he'll be speaking on preeclampsia, where we stand and where we are going. I would now request Dr. Amit Basu, the Clinical Secretary of BOGS, to read the biodata of Dr. Bamandas Mukherjee.
Thank you, Dr. Banerjee. Yeah, can you see the screen?
Yeah.
Okay.
Go ahead.
First, let us pay our tribute to the Dr. Bamandas Mukherjee. I'm talking about her in his initial days. He was born in 1878, was the fourth of the 5 sons and 2 daughters. His father was a clerk struggling to make 2 ends meet. Academically, he was brilliant, and most of his schooling was on scholarships. Unfortunately, his first wife died during childbirth, and this inspired him to take up midwifery. He passed out of medical college in 1906 and was in government practice till 1912, after which he started his individual practice. His fame as a sincere and dedicated practitioner soon spread beyond Bengal. He was appointed professor of Carmichael Medical College and conferred honorary FRCOG in 1937. He was a leader. He was the founder member and president of Bengal Obstetrics and Gynaecological Society. He was the first Indian and second president of FOGSI. He developed the institution we know today as Chittaranjan Seva Sadan. He was a fellow of State Medical Faculty of Bengal and was awarded Silver Jubilee Award by the Government of India. The love for his native village drove him to construct schools, water tanks, and work towards social and economic upliftment of masses. He was well versed in Hindu rituals and had a deep conviction in religion and philosophy. He personally conducted Durga Puja at his ancestral home. Being a true family man, he fostered more than 50 relatives, keeping them at his residence, educating them, and establishing them in life. The legacy continues. Dr. Bamandas Mukherjee's grandson, Dr. Basudev Mukherjee, is well established in life and a past president of Bengal Obstetrics and Gynaecological Society. His grandson, Dr. Bashab Mukherjee, is the immediate past secretary of Bengal Obstetrics and Gynaecological Society and derives inspiration in life from the great Dr. Bamandas Mukherjee. He is also the president in the make. This oration, it started in 1996. Dr. Bamandas Mukherjee Memorial Oration has been an integral part of the Foundation Day celebrations. He was stalwarts in different fields like Professor Arul Kumaran, Professor Raj Baveza, Professor Shukumar Mukherjee, Professor Amitabh Sen, Professor Amitabh Rudro, Dr. Praveen Matre, Professor N. Raja Maheshwari, Dr. Shailesh Puntambekar, Dr. S. Suresh, Dr. Alka Kriplani, Dr. Durusha have delivered this oration in the past. The Bengal Society and Mukherjee family is happy to have Dr. Sanjay Gupta as the orator of this year. Thank you very much.
Thank you, Dr. Basu. In fact, we are also very happy to have Dr. Basu Mukherjee and Dr. Basudev Mukherjee with us today for this oration. I would now request our Honorary Secretary, Dr. Zohar, to please present the orator to us.
Thank you, Dr. Banerjee. It's a proud privilege for me to present Dr. Sanjay Gupta, the past president of FOGSI, to us, who will be delivering 25th Dr. Bamandas Mukherjee Memorial Foundation Day oration. Dr. Gupta is currently the director of Gupta Hospital and Center for Research in Reproduction in Pune. It is very difficult to complete his attachments and his clinical acumen and his biodata in short time. But just to summarize, that he is the chair ethics committee figure. He was also the president of FOGSI in 2010. He is the president of DIPSI in 2013, that is the Diabetes and Pregnancy Study Group in India. He is the Secretary General of World Justice Organization, Chairman of the Technical Research Committee of the Indian Council of Medical Research, the ICMR, and the National Coordinator, National Eclampsia Registry. He is ex-chairman of the Ethics Committee, Maharashtra Medical Council, as well as ex-member of the Central Supervisory Board of PCPNDT. He is also an ex-member of Ethics Committee, Medical Council of India, and a national consultant in medical, legal, and ethical issues in obstetrics and gynecology. He is a known teacher, and he is a former honorary professor and postgraduate teacher in obstetrics and gynecology. He was awarded FRCOG honoris causa by Royal College of Obstetricians and Gynecologists, London in 2020 for his contribution in obstetrics and gynecology. And we all know that high-risk pregnancy is his area of research, area of interest for research for Dr. Gupta. Ladies and gentlemen, I think we have one of the best candidates to talk about today's topic, preeclampsia, and he will be talking preeclampsia, where we stand and where we are going. And on the 25th, Dr. Bamundas Mukherjee Memorial Oration. Dr. Sanjay Gupta, the screen is yours now. Thank you.
Thank you. Thank you, Dr. Zua, for that very kind introduction. And good afternoon to all my friends in Bengal. And I bring greetings to you from city of Pune. Presently, unfortunately, the Corona capital of our country. Not a very flattering description, but believe me, we are fighting it out, definitely. I'm extremely thankful to Bengal Obgynaecological Society, Dr. Dibyendu Banerjee, Dr. Bhaskar Pal, Dr. Sam, and the whole team, and especially the Mukherjee family, for bestowing me the honor of this prestigious oration. Dr. B.D. Mukherjee, who was the first Indian president of OXY, was not only the greatest of gynecologists of his time, but a great philanthropist and religious scholar, all rolled into one. He was a close colleague of the great Dr. B.C. Roy, and together had mentored and guided many young students in his time. With that kind of legacy, no wonder respected Basudhavda and my friend Basab have been such stars in our faculty. Especially when I came to know about the eminence of Dr. B.D. Mukherjee and the pioneering work that he has done in our faculty, I realized that it is huge responsibility to present this oration in his name. And to that, add to that the intellectual level of today's audience of my Bengal colleagues. I'm always impressed by the IQ of everyone that I have met from our faculty in Bengal. I think it is also a historical fact that the Bengalis are considered the intellectual community of India. This together made me take additional pains preparing this talk. To make it really fitting to the eminent oration personality of Dr. Mukherjee and the intelligent audience, I have divided this talk in two separate parts. In first part, I will be touching upon the upon the salient features of which we clinically encounter in preeclampsia and its management. But to me, the second part of the oration is very special because this, I believe, will be appropriately challenging to the gray cells of my audience. I hope that will be appreciated. So with tributes to the great Dr. B.D. Mukherjee, let me start my talk of today. Please feel free to interrupt if you don't hear me, or I'm now sharing my screen, and if you can't see that, Dr. Dibyendu, please let me know. So the National Eclampsia Registry of OXY ICOG statistics reveals that the incidence of hypertensive diseases during pregnancy to be high with a substantial incidence of preeclampsia. In our country, incidence of preeclampsia was found to be 10.3% and incidence of eclampsia 1.9% of all the pregnancies. That means, as in India, we have 26 million deliveries per year. We are dealing with 26,78,000 cases of preeclampsia and 4,94,000 cases of eclampsia every year. Really a gigantic task. Well, this is a new definition of preeclampsia, which was revised in 2014. It says hypertension developing after 20 weeks of gestation with one or more of the following, that is proteinuria, maternal organ dysfunction, or fetal growth restriction. It is important to note that this definition does not require proteinuria to meet the diagnostic criteria. The inclusion of fetal growth restriction in this definition may increase the number of women meeting the diagnostic criteria for preeclampsia and is therefore a significant change. This, of course, is the classical textbook classification for, and I think for this audience, I can definitely afford to skip it. It is the clinical classification which is more important to us. So clinically, the HDPs are classified as early onset preeclampsia, onset of proteinuric hypertension before 34 weeks of pregnancy. The maternal complications are more severe here. Low birth weight, fetal growth restriction, and iatrogenic prematurity are quite common. Late onset preeclampsia, onset of proteinuric hypertension after 34 weeks of pregnancy. Here the maternal complications are less severe, low birth weight, and fetal growth restriction is less common. Well, another useful way of classifying the hypertensive diseases is non-severe preeclampsia, that is blood pressure more than 140/90 and less than 160/110, no premonitory symptoms and normal HDP lab parameters. Or severe preeclampsia, BP more than 160/110 with or without premonitory symptoms, with or without abnormal lab parameters, or, this is important, blood pressure more than 140/90 with premonitory symptoms and or abnormal lab parameters. It is to be noted that non-severe preeclampsia may get converted to severe preeclampsia in a very short time, and the vigilance is very important. Well, considering the magnitude of the mortality and morbidity associated with HDPs, especially preeclampsia, there can be no two opinions regarding early and universal screening for these conditions. As the tests available today for screening are complicated and are costly, there is certainly a need for simplification. And that is where HDP Gestosis score comes in. This is an effective and feasible prediction policy. This is easy to use score, can be used for screening and prediction of preeclampsia. Process of risk scoring is like this. This score involves all the existing and emerging risk factors in the pregnant woman. Score of 1, 2, or 3 is allotted to each clinical risk factor as per its severity in development of preeclampsia. With careful history and assessment of women, a total score is obtained from time to time. And when total score is equal to or more than 3, the pregnant woman should be marked as at risk for preeclampsia. As one can see, this score covers all the risk factors and as per probability and severity. So all the details can be seen here. I'll be sharing this where requires this score for their practice later on. Well, unlike other guidelines which consider each factor as of equal significance, the Gestosis score gives weightage according to severity. While completing the score sheet, it allows points to be kept blank if patient is unable to give the history, which is not so in many other situations. It denotes the indication for available prophylaxis, like say aspirin or calcium, rather than claiming a high probability of prediction. Well, we applied this score retrospectively in our own practice of almost 300 patients in last 6 years. And this was the result which is in front of you. In early onset preeclampsia cases, 72% patients showed true positive prediction, but there were 28% patients with false negativity. Well, this high false negativity could be because the score was applied, as early as 12 weeks. Then in normotensive patients, 42% cases were false positive, and this may be due to number of primigravidas, which was quite high. The patients with high BMI were more, and also cases of multiple pregnancy were higher in our practice because of the IVF situation there. So even though this is the situation, it's important that we use this in our practice, because this simple method of gestosis score gives us good prediction value without any additional cost and seems worth adopting in our day-to-day practice. This gestosis score is now being prospectively studied by many of our teacher colleagues with their PG students in their dissertations. Well, biomarkers in prediction. And there are a number of good studies now coming in, and they make us really think about these biomarkers. In this so-called SCOPE study, 47 biomarkers were identified on the basis of a plasma sample at 14 to 16 weeks gestation from more than 5,000 women. The data suggested that prediction of early onset preeclampsia is attainable. However, EOP accounts for only a minority of the cases, and the burden of disease lies within the preeclampsia presenting at term. So early pregnancy prediction of term preeclampsia remains too poor to be of clinical use. And on basis of this data, the authors put forward a unique concept of two-stage screening, with screening in the early pregnancy for EOP and screening for LOP in the third trimester. This prognostic study in 2016 was also important. It showed that the ratio of S-split and PLGF is elevated before the clinical onset, but requires further clarification. So S-split and PLGS ratio of 38 or lower can be used to predict the short-term absence of preeclampsia in women in whom the syndrome is suspected clinically. S-split PLGS ratio cutoff point of 38 or lower also had value in predicting the absence of adverse maternal or fetal outcomes within 1 week. Okay. Well, SPREE study of 2018. This famous study by Nicolaides group used multiple biomarkers for prediction of preeclampsia in the first trimester itself, and came out with impressive figures of 80% prediction for early onset preeclampsia. However, prediction for term preeclampsia remained low. As we can see here, when multiple risk factors with MAP plus uterine artery Doppler, PAPA and PLGF are all assessed together, the predictivity for EOP is as high as 81%. But for late onset preeclampsia, it is still 43.5%. Well, so what is the present consensus about the prediction with all the various organizations? They all say that universal screening is recommended, but there is no single effective screening test as yet. None of the tests proposed till date to predict the at-risk population for preeclampsia qualify to be recommended for general population screening. And thus, assessment of clinical risk factors helps us to be more vigilant. A careful history taken early in the first trimester can warrant attention for effective prediction and prevention towards mothers at risk very early. I have always felt that we leave the history taking to the junior-most colleagues, when they join in, but it's important that we teach them a very detailed history taking, which can come up well in any of our obstetrics situations. Well, FIGO and ISSSP viewpoint, they also agree that no first or second trimester test or set of tests can reliably predict all cases of preeclampsia. However, the combination of risk factors all taken together may help in identifying cases which will be helped by aspirin. FIGO as ISSSP support first trimester screening for risk of preeclampsia, but also say that this should be done if it can be integrated into the local health system and the cost effectiveness of this approach remains to be established. Well, when we come to use of biomarkers in diagnosis, there's an entirely a different aspect, because what we find here is diagnosis of preeclampsia is based on traditional but unreliable and non-specific clinical markers, namely blood pressure and proteinuria. Both are subject to observer error and poor test accuracy for identifying women at risk of adverse outcome. So this clinical uncertainty leads to a lot of problems, a lot of additional tests, and trying to find out, whether the case at hand is really a definitive preeclampsia case or not. So here's where the role of PLGF or biomarkers come in. So in this Pelican study, they concluded that the women presenting before 35 weeks of gestation with suspected preeclampsia, low PLGF has high sensitivity and negative predictive value for preeclampsia within 14 days. So this study suggested that the PLGF testing presents a realistic and innovative addition to the management of women with suspected preeclampsia, especially those presenting preterm. Another study, the MAPLE study, also agrees that when the PLGF values were revealed to the doctors who were treating the patient, the revealed PLGF was associated with lower perinatal mortality and small for dead babies, but it appears to lead to earlier delivery with more neonatal respiratory morbidity. The latest study in this field is a parrot study, and this shows that if a PLGF test is made available to the treating clinicians, then there is definitely reduction in serious maternal adverse events. The clinical use of PLGF measurement could present a change in antenatal care that improves speed of diagnosis and improves outcomes in pregnancy. I would also like to mention two other promising biomarkers which are on the horizon for prediction and diagnosis of preeclampsia. The first is the Congo red test. This is urine test which identifies misfolded proteins with color change. It is under evaluation because in certain situations like renal problems, it can come as false positive. Preeclampsia screening test with serum endoglin. We have ourselves developed this placental origin receptor-based protein biomarker test with high prognostic and diagnostic value, which is with us under validation. This is how this test looks. This is a point of care test, and after you're using serum from the patient, it can be used almost like a card test in with the preeclampsia patients for correct diagnosis and prognosis also. So now we come to management of preeclampsia. And believe me, I'm just going to touch upon only the salient features just for the completion of the topic at hand. So I'm not going to go into the details of it. So let's talk about antihypertensives. We know that all guidelines agree that severe hypertension more than 160, 110 requires urgent treatment in a monitored setting. Acceptable agents for this include oral nifedipine or intravenous levetolol or hydralazine if you have that. And oral levetolol may be used if these treatments are unavailable. Mild hypertension, and this is where the interesting part comes, that World Organization Gestosis and ISSSP have now agreed that blood pressure consistently at or above 140/90 should be treated, aiming for a target diastolic BP of 85 millimeters and systolic between 110 and 140 to reduce the likelihood of developing severe maternal hypertension and other complications such as low platelets and elevated liver enzymes with symptoms. This may come as a little surprise to many of you, but this is based on the landmark CHIPS trial. And the effects of less tight versus tight control of hypertension on pregnancy complications was studied in this wonderful trial. Women were randomly assigned to less tight control, that is target diastolic BP of 100 millimeter, or tight control, target diastolic BP of 85 millimeters. They found no significant between group differences in the risk of pregnancy loss, high level neonatal care, or overall maternal complications. but less tight control was associated with a significantly higher frequency of severe maternal hypertension. Well, now we come to the delivery decision, which is as per the WHO guidelines, gestational hypertension, pregnancy can be continued till term, mild preeclampsia to be delivered at 37 completed weeks, severe preeclampsia to be delivered after 34 completed weeks. Eclampsia should be delivered once the mother is stabilized after magnesium sulfate, and labor induction with appropriate method can be carried out safely. Cesarean section is done for obstetrics indications only. Timing of delivery to offer women with preeclampsia delivery at 37 weeks of gestation. Prior to 34 weeks, management is expected, and with elective delivery not considered due to worse neonatal adverse outcomes. Between 34 and 37 weeks, it's a little controversial till now, but now these next two studies have come in. And this is a Habitat 1 study. In this trial of 756 patients who were having no severe features of preeclampsia and with beyond 36 weeks of gestation, they were allocated to expectant management or induction of labor. The induction of labor option was associated with a significant reduction in adverse maternal outcome, including new onset severe preeclampsia, HELLP syndrome, eclampsia, and what have you. There were no differences in rates of neonatal complications of cesarean delivery, so induction of labor was recommended. Then there was Habitat 2 study, and this study randomized the patients for management of between 34 and 37 weeks of gestation. The result showed that immediate delivery through either induction or cesarean section might reduce the small risk of adverse maternal outcomes compared with expectant monitoring. However, immediate delivery may increase the risk of neonatal respiratory distress syndrome. So it will raise a few eyebrows in our country especially, but we will have to decide for our own circumstances. This latest trial called Phoenix trial also brought out strong evidence to suggest that planned delivery reduces maternal morbidity and severe hypertension. And compared with expectant management, with more NICU admissions for prematurity, but no greater neonatal morbidity. This trade-off should be discussed with the women with late preterm PE to allow shared decision-making on timing of delivery. That is what they say. Now, intrapartum management, the two important goals of prevention of seizures, so use of magnesium sulfate, control of hypertension with nifedipine or labetalol. Mode of delivery, it depends on the urgency, cervical Bishop score, gestational age, severity of FGR, and so on. Induction of labor, prostaglandins can be used, mechanical dilatation can also be used, and augmentation of labor with oxytocin is allowed. Cesarean delivery with severe FGR or reversal of end-diastolic flow on color Doppler. Important part is the fluid management. Inappropriate use of fluids can cause pulmonary edema, and so fluid restriction should be to 80 ml per hour or 1 ml per kg per hour to reduce the risk of pulmonary edema. Preventing PPH is very important because possibility is more due to magnesium sulfate. Active management of third stage and prophylactic administration of oxytocin and prostaglandins can be used. Methyl ergometrin is contraindicated, and we have to note that average blood loss of labor may not be well tolerated by these patients due to hemoconcentration, and blood pressure readings could be really misleading. Post-delivery management. This is something that we need to pay heed to because close vigilance for eclampsia, PPH, HELLP, and all complications is important. The National Eclampsia Registry of ours showed that in 13% of the cases, the eclampsia occurred first time after delivery. So postpartum eclampsia. This is very important. So postpartum use of NSAIDs should be avoided. Antihypertensive therapy and magnesium sulfate should be considered for seizure prophylaxis even after delivery. And pulse oximeter, especially when you are going to discharge the patient, maybe on third or fourth day, just take the SpO2 and make sure that it is 95 now in today's COVID world, we have understood the importance of SpO2, and I think everywhere people are using that, but we have been advocating it from before for these cases. Post-discharge and long-term surveillance is important. And now, friends, having finished the part that we all know about, now we start with more important second part of this talk, which I hope will be really thought-provoking. These are the two people that you see in front of you, and Professor James Roberts and Professor Christopher Redman, who between them are responsible for most of the new knowledge and concept which are now driving the preeclampsia research in the right direction. Their unparalleled dedication is truly astonishing. I've had opportunities to interact with them, and which have really inspired me to work in this field. So let's start with some basic thoughts for the intelligence audience that we have with us today. Right. So why is it called as preeclampsia, first of all? Well, eclampsia was a convulsive disorder of pregnancy known for 1,000 years. Hypertension was noted in these cases, and it was almost always accompanied by proteinuria. Even without seizures, this indicated a potentially rapidly progressive disease leading to maternal and infant morbidity and mortality. It preceded seizures, that's why it was called as preeclampsia. So far and so good. Well, we have to remember that these were serendipitous findings. High blood pressure and proteinuria were actually accidentally found with cases of eclampsia and before that. So they were not really sensitive or specific, not even the most important pathophysiological or prognostic factors. Nonetheless, research was focused only on understanding their cause for almost 100 years. And not surprisingly, no progress was made for a long time. And we know, in our recent days that this was called as disease of theories, and many theories from worms to toxins to lightning to direction of North Pole were entertained. And Zuspan quite rightly described this wonderfully, that preeclamptic woman has been blistered, bled, purged, packed, lavaged, irrigated, punctured, starved, sedated, anesthetized, paralyzed, tranquilized, rendered hypotensive, drowned, dehydrated, given diuretics, mammectomized, oophorectomized, and forcibly delivered. So really all sorts of mumbo jumbo was used without real evidence. It took many years to realize that preeclampsia is not only pregnancy-induced hypertension. In the last 40 years, there has been an explosion in knowledge relevant to our understanding of preeclampsia. Now it is recognized that preeclampsia is a multi-systemic syndrome. So what are the revelations in last 40 years? Roberts in 1989, discovered the endothelial dysfunction. The role was very important. Redman in 1999 showed how increased inflammatory activation is playing a role. Hubel in 2006 discovered the metabolic changes which are profound, and abnormal balance of angiogenic and entheogenic factors were discovered by Maynard and Kurumanchi in 2011. And furthermore, there has been a substantial increase in the understanding of the process of trophoblast invasion, long recognized as a key feature of preeclampsia. Well, there is a paradox. Friends, in spite of more understanding of pathophysiology, the ability to predict, prevent, or treat preeclampsia has not increased at all. And presently, when we so-called treat preeclampsia, we are only treating the symptoms and not the cause. So we are only giving maybe paracetamol for fever exactly in a similar manner. This is so because when preeclampsia is clinically evident, the process is no more reversible. So the question to be answered is, if we know so much about preeclampsia, why haven't we cured it so far? To answer it, we need to do some rethinking. So let's start in the beginning. The etiologically preeclampsia develops in 2 stages. Asymptomatic stage involves abnormal placentation, which is followed by placental elaboration of soluble factors that enter the maternal circulation and cause widespread endothelial dysfunction with signs and symptoms, which is called as maternal syndrome. Right. And well, no self-respecting preeclampsia talk can be without this particular slide. And as you can see, the central one shows inadequate placental perfusion, that is failed remodeling of placental vasculature. And this remodeling of maternal spiral arteries leads to increased diameter of terminal vessels. Because of replacement of smooth muscles, sphincter-like action is reduced. But the original conclusion was this remodeling leads to large increase in the volume of the flow. But Burton in 2009 pointed out that flow is only increased 2-folds, but velocity of the blood is reduced almost 10-folds from 1 meter per second to 10 centimeters per second. So failed remodeling does not really reduce the flow of the blood, but it keeps the speed high. Then there is immunology, and the remodeling depends on tropoblastic invasion, which depends on decidual, that is maternal, and tropoblastic, that is fetal and antigen interaction. This immunological interaction is intricately altered with HLA-G antigens of the trophoblast, which provides protection from NK cells. Now, HLA-G are protective antigens which replace other HLA class 1 antigens on the tropoblastic cells, and that is how they provide the protection to the baby. Well, this is where importance of exposure to maternal antigen integrally is involved. The concept of primiparity was presented by Robillard in 1999. Robillard propagated that longer exposure to sperm antigens before pregnancy is also protective. This is now proven with a lot of example, more so in ovum donor pregnancies, as my IVF colleagues would, I'm sure, more than agree. Right. So what are the effects of inadequate perfusion? Intermittent hypoxia causes oxidative stress followed by release of anti-angiogenic proteins, namely S-plate, activation of inflammation, and greater velocity of the blood that we talked about causes fragmentation of syncytial trophoblast, leading to more deportation of cells and causing more inflammation. So inadequate, what is to be remembered? It's inadequate and not reduced placental perfusion that we talk about. It is not always reduced perfusion, but adequacy is important. When tropoblastic mass is increased, like in multiple gestations and hydropic placenta, placental perfusion is normal, but it is still not adequate. Now, let's talk about the maternal syndrome, the so-called stage 2. It is characterized by the hypertension and proteinuria. Pathological examination of organs show hemorrhage and necrosis, which suggests reduced oxygen perfusion. Also, other changes seen in the maternal organs are like vasoconstriction secondary to increased pressure sensitivity, activation of the coagulation cascade with microthrombi, loss of fluid from intravascular space that leads to a reduction in the circulating blood volume. Interestingly, all these are consistent with endothelial dysfunction, but previously have been described separately and as different etiologies, and that's how people got into trouble. So the important question again is whether inadequate placental perfusion alone is sufficient to cause preeclampsia. The answer is a big no. Why? Because women with FGR infants and 1/3 women with preterm births also showed same remodeling failure in most instances. Right. So the conclusion was effect of inadequate perfusion in preeclampsia is modified by the maternal constitution, and that means maternal diseases like gestation diabetes, maternal lifestyle like obesity and smoking, genetics, environment, and even normal physiological changes of pregnancy where there is increased inflammatory response. So implications are very important. It implies that, and this, please listen to it carefully, it implies that inadequate uterine perfusion may not only be insufficient to cause preeclampsia, but may also not be fully necessary for preeclampsia in some cases. With a combination of maternal factors and inadequate placental perfusion together determining outcome, preeclampsia could occur with very reduced placental perfusion and almost no maternal contribution, or conversely with minimally reduced perfusion and a profoundly abnormal maternal constitution. This is a very crucial proposition which may help us in explaining many subtypes of preeclampsia that we encounter. And one such explanation was provided by Professor Redman, explaining the differences between EOPE and LOPE. And this is a wonderful model that you can see here. The Redmond explained that early onset preeclampsia is because of classical failed vascular remodeling. As we can see here, leading to oxidative stress placenta and syncytial trophoblast, causing anti-angiogenic and inflammatory effects. While in late LOPE, what we see is he proposed a simile of pod-bound placenta, and this is very interesting, which means that at term, some placentae overgrow the vascular supply, leading to syncytiotropoblast stress and then cause preeclampsia. Naturally, the presentations are going to be very different. Well, this was much better model to explain the situation, but we are still left with identifying correct linkages of inadequate perfusion to maternal syndrome. And that could be the reason why we are not able to predict or prevent preeclampsia, because we have been considering wrong links. This is due to the fact that in preeclampsia, the clinical presentation is variable. Lab studies are variable. Maternal populations are variable. That is why many preventive strategies work in small homogeneous populations, but not in larger populations, which we saw in prevention with calcium supplementation in our own country. Right. So the clinical variability in preeclampsia is tremendous. Gestational age at occurrence, severity of the symptoms, presence or absence of very high blood pressure, variable rate of progression, recurrent versus non-recurrent preeclampsia, with or without FGR, with or without proteinuria, with or without organ involvement, for example, liver and kidney, with and without obvious predisposing factors. So can these be various subtypes and not just variable presentations of a single entity called preeclampsia? Well, I believe that there are reasons to think so. Because, if we see, we see so many variations, like here, there is increased mortality is seen with early onset preeclampsia. Maternal risk is increased with recurrent preeclampsia. Lab reports are variable. Triglycerides are not increased in all preeclampsias. Oxidative stress is not evident in all cases of preeclampsia. And not all women with preeclampsia have elevated split levels. So there is a lot of evidence pointing towards the subtypes. So why have we not recognized this evidence of subtypes? Because we have focused only on hypertension and proteinuria for a long time. We have ignored the variables seen in front of us, and we are trying to fit available data in a single model. So what happens when we use a lot of statistical jargon and means and standard deviations? Well, generally the outliers get neglected, or then they remain hidden. Nobody does this purposely, believe me, but they remain hidden. So implication of the existence of subtypes. Friends, the bad news is the predictors will not predict all cases of preeclampsia, which we already know. The treatment will not prevent all cases of preeclampsia, which again, something that we have encountered. But the good news is predictors will predict some cases of preeclampsia, and directed treatment will prevent some cases of preeclampsia if we can identify subtypes of preeclampsia. So what are the potential subtypes? Well, there are clinical presentations, early, late, severe, mild, with or without FGR, epidemiological presentations, pregnancy phenotypes, demographics, and of course, pathophysiology. How do we recognize these subtypes? First, we need the awareness for these subtypes. Not to assume all preeclampsia is the same, not to force all the data to fit into one model, to pay attention to outliers, be open-minded, and look at the data without preconceived ideas. And this is where the next real landmark study comes in. And this is a wonderful study by a Canadian team from Toronto. They actually did the gene expression clustering. And this gene expression profiling is going to be, of course, the new paradigm. And this Catherine Levy et al. Created a large clinically relevant human placental microarray dataset applying unsupervised, that means unbiased clustering. They just collected this gene expression data from all their patients. And when they had different PE placentas, they grouped them together, and they found that there was 3 groups: maternal group with healthy placentas and term delivery, canonical or typical exhibiting expected clinical and histopathological features of preeclampsia, and immunological with severe fetal growth restriction and evidence of maternal antifetal rejection. An additional subclass of preeclamptic placentae was also revealed due to chromosomal abnormalities in some of these samples. So solely based on similarities in gene expression, they proposed the model of placental outcome and PE etiologies. The 4 different clusters that they could identify with this gene expression profiling help us denoting different subtypes. And this is a beautiful chart that we have in front of us. Now with this gene expression profiling, we can look at subtypes as we are shown here. The cluster 1, where you find normal placentation and immune compatibility will lead to healthy placenta, and we can expect term delivery with good outcome. But if other factors, like infection or abruption, they come in, then the patient might deliver prematurely. On the other hand, if there are other maternal risk factors like increased age, high BMI, chronic hypertension, GDM, multiple pregnancy, placenta still may be normal, but the mother may develop late onset preeclampsia. Well, second situation let's look at. That is cluster 2. It may be the result of primary defect in the placental function, leading to reduced placental perfusion, hypoxic injuries, and increased production and secretion of placental factors. For example, split and endoglin into the maternal blood, culminating in early onset preeclampsia development. Well, finally, the cluster 3, incompatibility between the mother and the fetus may evoke an immune rejection of the placenta, resulting in extensive fibrin deposition, secondary placental insufficiency and dysfunction, and fetal growth restriction, as shown here in cluster 3. The development of preeclampsia in this group, this called as immunological PE, seems to depend on the presence of immunological risk factors like short cohabitation or, interestingly, type A blood group, and the possible absence of immunological protective factors such as previous exposure to paternal antigens or a type B group. Patients with placental, B group. So it will depend on whether you have protective factors or you don't have protective factors, whether you are going to get actually the immunological preeclampsia or no eclampsia but only FGR. And finally, patients with placental chromosomal abnormalities may exist in all these divergent disease paradigms, further affecting the placental gene expression profiles. And this is the 4th cluster that they could identify with their molecular studies. So this was a beautiful study And this particular study tells us a lot about even epigenetic and placental functions. We now know that emerging evidence suggests that healthy placental function requires locus-specific methylation changes at specific time points in development. Maternal exposure to severe stressors such as environmental pollutants, nutritional factors, psychological stress or maternal depression during and even sometimes before the early pregnancy can increase the fetus's risk for suboptimal growth in a wide range of organ systems and for developing a variety of disorders in adulthood. These epigenetic regulations play a role in the pathophysiology of preeclampsia. Interestingly, placental gene expression changes have shown to precede preeclampsia, and candidate gene susceptibility loci where they occur are now being identified. This has wide-ranging implications in discovery of predictive markers of preeclampsia, which may improve the ability to provide early treatment and monitor women with high risk of preeclampsia. So finally, how do we study the subtype? We need to determine mechanisms driving subtypes for this. So risk factors in the mother, age, BMI, nutrition, lifestyles, and comorbidities, maternal profile, which is very important, pregnancy profile with like ICSI or own donor pregnancies, stressors during and before pregnancy, genetic and epigenetic profile, all will have to be considered. So in conclusion, this knowledge of existence of preeclampsia subclasses will be key for the generation of robust biomarkers capable of identifying all these groups early in the gestation and allow for development and implementation of really etiologically best treatments aimed at specific subclasses of this disorder. As in other fields of medicines, such as oncology, this personalized medicine approach will no doubt improve short and long-term health outcomes for both mother and the child. And believe me, there are going to be now new medicines, probably anti-inflammatory, safe medicines in preeclampsia. Because one of the things now is coming to the fore is how the low dose aspirin is acting. It's not just because of whatever it does to thromboxane A2 and prostacyclin and platelet aggregation, but it's probably acting as also anti-inflammatory effect with actually reducing the inflammation in these patients. Finally, preeclampsia is a syndrome. It is not a disease. There is abundant evidence indicating subtypes of preeclampsia. Recognition of subtypes and deciphering different pathophysiologies for early prediction and to direct individualized therapy as per the subtype is the future. So let's look at every case of potential preeclampsia with close lens and not miss out on the subtleties it presents. I think that's actually the fun of obstetrics. If you are in obstetrics, every case is a different case, and if you really take interest and look at this, then our job becomes not just mundane job, but we really enjoy managing and treating these various patients. So with that, I thank you, the Bengal Obstetric Society, especially the president and the president-elect and the whole team and the Mukherjee family. I think it was a great honor for me to give, especially this being the Silver Jubilee oration in the name of Dr. B.D. Mukherjee. And I really feel humbled doing that. Thank you so much, all of you.
Unmute yourself, Dibyendu.
Thank you, Dr. Gupta, for this very interesting talk, which may take us to the 22nd century. We've learned many new things, a new etiopathology, a new classification, a new cluster-wise treatment of preeclampsia. And thanks for this wonderful oration. I would request our Honorary Secretary to kindly virtually present the plaque which is customary for this oration. Dr. Zoha, please.
Yes, Dr. Banerjee. Give me a sec. Let me share the screen. Right. The Plex says, on behalf of the members of the Bengal Obstetric and Gynaecological Society, it is our great pleasure and privilege to honor Dr. Sanjay Gupta, FICOG, LLB, FRCOG, Director, Gupta Hospital and Center for Research in Reproduction in Pune, National Consultant in Medical, Legal and Ethical Issues in Obstetrics and Gynecology, Chairman, Ethics Committee, FIGO, President, Foxy 2010, President, Deepsy 2013, for delivering the 25th Dr. Bamandas Mukherjee Memorial Foundation Oration live on Saturday, July 25th, 2020. It's signed by President Dr. Dibyendu Banerjee and myself as Honorary Secretary of Bengal Society of Obstetrics and Gynecology. Dr. Gupta, congratulations and thank you.
Thank you, Dr. Sam. Thank you very much.
It's really a pleasure to have you among us. Though unfortunately we couldn't hear you physically, so obviously we'll send it to your address. Thank you so much.
Please
My pleasure always, yes.
So please share your mailing address with our office.
Of course, yes, I'll do that. I'll do that. Thank you so much. Thank you so much.
TJ, take over.
Well, thank you. And thank you, Dr. Zoha. And thank you, Dr. Gupta, for your excellent speech. I would like to address the viewers of our session. It is customary for us to organize a debate and Taposhi Nag Memorial short paper session in the Foundation Day program. But unfortunately, we couldn't do that because we thought it wouldn't be suitable in this virtual program. So I hope you enjoyed the academics the day that we had arranged for you. And now I would request Dr. Samsud Zua, Honorary Secretary of BOGS, to offer the vote of thanks.
Well, my thanks goes first to the participant, the attendees who have attended online program of our Foundation Day. It's a first of its kind, a virtual Foundation Day celebration. It's a difficult time, and so we had to adapt ourselves in this difficulty. My sincere thanks goes to orator, Professor Tim Dreckert from UK, and Dr. Sanjay Gupta from Pune. We are really grateful to you for your excellent deliberation and making us extremely happy with your deliberation. My sincere thanks to Dr. Asha Bakshi, as the symposium speaker, as well as our own Dr. Sir Kedarnath for our deliberation as well. My thanks to the entire faculties, including the president, Dr. Oscar Paul. Actually, it was supposed to be, if there was no COVID, it was supposed to be his Foundation Day. He was supposed to be president now, and he would have taken all the lead and it would have been this show. But of course, because of this situation, we had to do it. But Dr. Paul from behind the scenes has really helped us by mixing two orators, and my sincere thanks and gratitude to him for this. Our senior vice president for chairing the session and his contribution. My sincere thanks goes to our academic partners, the GSK Pharmaceutical, as well as the Biogaphical Pharmaceutical. In fact, all the logistic support has been taken care of by Biogaphical. So my sincere thanks to them. My thanks to the entire BOGS Managing Committee for their support, their overwhelming support, and their contribution in making this program a success, including especially Dr. Tulika Jha, our Joint Clinical Secretary, Dr. Amit Basu, our Clinical Secretary. They have really worked hard to make this program a successful one and organizing it very smoothly. Of course, it is incomplete without thanking the members, because immediately before the Foundation Day program, we had our first virtual general body meeting, and we had quite a few participants, and they have really helped us by endorsing our resolution so that we can continue till November 2020. Thank you, ladies and gentlemen. Thank you so much. And last and not the least, I would like to thank our president, Dr. Dibyendu Banerjee, for willing to take this committee till November, though I don't support him very much. I hate him for this because we have to do till November. But thank you for your courage, and thank you for your leadership, and thank you for agreeing to get this done, prolonged till November. Thank you, ladies and gentlemen. I think every good thing must come to an end, and this is the Foundation Day. We all will remember in future the virtual 3 hours academics without any pause. And thanks very much, and goodbye.
Thank you. Thank you.
Well, we had our hiccups, we had our loopholes. I on behalf of the managing committee, would apologize for the hiccups.
Fantastic program.
But we sailed through.
We can't expect anything better than this. Fantastic, flawless, absolutely.
Thank
flawless.
you.
Now
No, I didn't mute in the proper time. That's
no, that's
That's okay. That's okay. That's part of the joy.
in all OA programs, these minor mistakes are bound to happen at every
छोटी बातें ऐसे होते हैं।
बड़े-बड़े शहरों में छोटी-छोटी बातें।
Where is the dinner tonight, President?
Come to my house, Amrut and dinner.
इस आगे जाने ठीक छोड़ देता हूँ।
आगे जाने मने এখনো তো রাত হয়নি
আচ্ছা
দুপুরের প্রোগ্রাম আজকে লকডাউন
ও তার মানে মাঝখানে ভিডিও অফ করে খেয়ে এসেছে
শ্যামল we are still
আমরা সবাই ভিডিও অফ করে খেয়ে এসেছি
না we are not official
অফিশিয়াল ও অমৃত খাওয়াবে বলছে তুমি এখন অফিশিয়াল করছো
আচ্ছা একটা জিনিস
people are listening to us
hello
people are listening to us, so we are official till now.
Okay, so let's go unofficial. Okay, goodbye.
Goodbye. Everybody, it was a nice program.
Nice program.
No doubt.
I enjoyed the 2 orations very much.
Very much. Both the orations were fantastic.
Very good.
Dr. Gupta's was also very nice.
Very good. Very interesting.
Very interesting, and খুব ভালো ছিল.
Okay.
Tim was excellent, and
bye.
Bye to all of you.
See you in the WhatsApp group. Okay.
A picture pathao, picture.
हाँ.
Photo pathao.
Photo तुले नहीं